Good afternoon, everybody. My name is Paul Martin. Even though I don't sound it, I'm actually a local. I'm at the University of Miami. So I would like to welcome you all here this afternoon for what is really going to be a very exciting program. I've already learned one lesson today, which I'd learned before, which is never schedule patients on a day you're planning to leave early, because inevitably there's a delay. So I would like to thank Danielle for her fortitude. I only arrived here literally about 3 minutes ago, and she didn't seem flustered at all. So congratulations, Danielle. So we've got a great group of speakers and topics, and I think this is going to be a very informative program. We just have a few introduction slides I'd like to run through first. And actually, could you advance the slide, please, for me? Okay, this is one of a series of conferences that have been held around North America over the last several years under the auspices of the GI and Liver Association of the Americas, so-called GALA. And as you can see, these have been held in major cities, not only in the United States, but also in Montreal in Canada. Next slide. So earlier this year, there was a similar program in Dallas, and now we're in Fort Lauderdale. There are two sponsors of this conference series, GALA, which I've mentioned already, and also the Texas Liver Institute. Here are the sponsors who we'd like to recognize and thank. There are diamond-level sponsors, including AbbVie and Shionogi. Platinum sponsor is Intercept. And then on the right-hand side, Dovey, Asahi, and Gilead have also helped sponsor the meeting, as well as Alexion, Ecosense, EHRC Technologies, Janssen, Prometheus, Salix, Shire, and Takeda. We would like to thank especially Intercept Pharmaceuticals for sponsoring our welcome reception this evening, which is at 5:30 in the Ocean Ballroom foyer. And I think by the time we're through this afternoon, all of us will be looking forward to having something cold in a glass in our right hand. There are also some industry-sponsored symposia as part of this conference. And on Saturday morning, we have a presentation on managing patients with chronic liver disease with thrombocytopenia prior to a planned procedure, presented by Catherine Crow from UT San Antonio. And later on in the morning, we have an update on hepatitis C management MAVRED, presented by Bruce Bacon from St. Louis. There are parallel sessions on Saturday morning, and your assignments are on the back of your badge. And this covers a variety of topics, including GI woes from head to toe. Now, very importantly, this is a CME meeting, and also, importantly, there's also MOC credits available for participating in this educational program. You're required to complete a program and certificate activity to receive credit. And this will be available starting Saturday afternoon on the GALA app, and will also be emailed to you following the conference. To receive up to 11 MOC points, you will participate in the same activity with an additional post-meeting questionnaire required by the ABIM. And at that time, you will be asked to provide your ABIM number and date of birth. We wish to thank the following companies for sponsoring and supporting this CME activity: AbbVie, Gilead, Intercept, McElrod, Prometheus, and Salix. And finally, the educational objectives. On completion of this conference, participants should be able to describe evolving patient management and treatment strategies for chronic liver disease and GI disease, integrate significant advances in therapeutic and diagnostic modalities into their clinical practice, apply the latest clinical research, including future therapies, and their role in the context of the current clinical paradigm. Disclosures: all faculty and staff involved in the planning or presentation of CME activities provided by the Annenberg Center for Health Sciences at Eisenhower are required to disclose to the audience any real or apparent commercial financial affiliations related to content of the presentations or enduring material. Full disclosure of all commercial relationships must be made in writing to the audience prior to the activity. Staff at the Annenberg and at GALA have no relationships to disclose. So this is going to be interactive in terms of answering the questions. So pre and post questions will be done via ARS, so please have your keypads ready. And then slides and recordings from the conference will be available on the following website, the GALA website. Okay, so again, those answers will be available tomorrow. And I would like to emphasize that MOC as well as CME credits are available for this meeting. I want to start off the afternoon with our liver section, and the chairperson is going to be Nancy Rao, who is Chief of Hepatology at Rush University Medical Center. She is very widely published in a number of areas in liver disease, including viral hepatitis. And she will also speak to us on hepatitis B, which treatments are currently available and what is on the horizon. Nancy?
Thank you so much, Paul. It's a pleasure to be here. Your weather is just a little bit more delightful than Chicago's. These are my disclosures, and the slides are all in the book, so that does help a little bit. For an overview, there's three main buckets that we're going to discuss in this 20-minute segment. First, just a general guideline approach to hepatitis B management. Our current available options about hepatitis B therapy and the nuances subtly for those, and then kind of like the future of where hepatitis B hopefully might be transitioning towards. When we consider standard of care in our current model, we know we have goals of therapy, we have endpoints of therapy, not just like do we stop and start, but actually the global endpoints, what indications we have for therapy, our treatment strategies, and then the definitions of response, which ultimately guide when we consider who can be stopped and who needs to continue treatment. So that's kind of the structure of what we'll start with the first point. When we think about goals and endpoints, our number one goal is to prevent morbidity and mortality related to liver disease, predominantly cirrhosis and liver cancer. We have a number of side goals, such as maternal childhood transmission, hepatitis B reactivation, and then the few extrahepatic manifestations of Hep B that are well recognized, so that there are some other things that we do capture when we're talking about goals. And when we discuss endpoints, obviously, the most optimal endpoint would be getting rid of the virus, which is not quite tangible. So now the optimal endpoint is surface antigen loss. Unfortunately, that's not quite as common, so we use something that we also understand that's highly associated with better clinical outcome, and that's suppression of our DNA. We have two predominant guidelines. I will show you a slide in a little bit that looks at many other options, but EASL, or the European Association for the Study of Liver Disease, and AASLD have both recently published and updated their guideline. There is some nomenclature differences, so the terminology that is used is a little bit different. That's important when you're reading literature in Journal of Hepatology compared to maybe hepatology, because they might be using two different labels for the same disease state. But what we understand from both of the guidelines, and there are subtle differences, but they are still going to use E antigen status, hepatitis B DNA, and ALT to make treatment associated decisions. And they still understand that even if the bucket is slightly differently labeled, that the management options are very similar among the guidelines. Sorry. When we talk about the EASL updates, this first bucket is the individuals who should be treated. There weren't too many changes here. The bottom bullet shows an individual who has a hepatitis B DNA greater than 20,000 international units and has an ALT greater than 2 times upper limit of normal is appropriate for therapy irrespective of histology or whatever we think is in the liver. So that's our standard individual who should be treated, E antigen status aside. When we look at the top bullet, again, E antigen status aside, if there's felt to be histologic activity, again, we don't usually do biopsies, but if you did do a biopsy or there's evidence that you're concerned that there's histology that's abnormal, again, this is an individual who is appropriate for therapy if their DNA is greater than 2,000 international units. And then anyone with cirrhosis, really irrespective of the level of DNA, is appropriate for therapy. Now, what's a little more novel in this iteration of the guideline is that there's a group here that may consider therapy, starting to understand that age is a component of hepatitis B management that probably has previously not come into play other than we're talking about liver cancer screening. If you are greater than 30 years old, which makes me feel great because I've been old for a long time, right now everyone over 30 is old. If you have active hepatitis infection and you have persistently normal ALT, you now have an option where therapy actually is recommended as a discussion point, not necessarily mandated, but discussion point. And then you could also think about treating individuals who have a family history of cirrhosis or liver cancer. So this really gives us a lot of wiggle room outside of our more traditional black and white guidelines that made it a little hard to take some of these groups you thought might be at risk. Now, I want to apologize. The AASLD guidelines were a little harder to cut and paste, but you can see on the left-hand side, E antigen, on the right-hand side, E antigen negative, and there is a lot of overlap, even though it's kind of in fine print. So if we look at our E antigen positive individuals, again, abnormal ALT, high replication, they're appropriate for therapy. With the caveat that if the DNA is kind of close to that 20,000 international unit, they might be seroconverting, so you do have the ability to kind of monitor them for a period before engaging them in therapy, but not a long period. On the very bottom, in that blue is don't treat, purple is treat. If your ALT is solidly normal, less than or equal to the upper limit of normal, and your DNA is elevated, that's a group of individuals who is not recommended for therapy right now by our guidelines. And then if you're in the middle there's just kind of monitoring recommended. Slightly more conservative, those that are E antigen negative. We've always known that from our guidelines. Here, ALT, that's elevated, greater than 2 times upper limit and normal. And a hepatitis B DNA greater than 2,000 is the trigger. Monitoring is for those that are in that individual group, and then you do not treat individuals who have a DNA less than 2,000 if their ALT is not elevated. Why do we concentrate still so much on ALT? And what's the definition of ALT? Well, we've all known for a long time that it's not whatever our local hospital lab tells us a normal ALT is. This is all based on the population, and as our population is diabetic, obese, we recognize that those ALT levels are often too elevated. So you can see on the bottom that although there are subtle differences between the traditional AASLD and then the newer AASLD guidelines, an ALT in a man greater than 35 is elevated, and greater than 25 in a woman is elevated. It used to be a little more conservative at 30 and 19. But you can certainly demonstrate from that bar graph that when you pass between 30 and 40, you start to see more necroinflammation and more risk linked to that ALT. And that's where those recommendations come from. And when we look at our guidelines, again, this is now expanding beyond just AASLD and EASL. We have the US algorithm, we have Apostles guidelines. There is a lot of consistency in high DNA, abnormal ALT, as being a very black and white starting point for considerations of therapy. All the others are a little more subtle, but it's uniquely, it's not unique, it's universal across the guidelines that these are standard groups that should be treated. So therapy options have definitely evolved. We have a lot of agents that are actually FDA approved for hepatitis B therapy, but we have actually very few that are considered first-line therapies. Although lamivudine was a breakthrough all-oral agent when it was made available in 1998, and then adefovir in 2002, we know that these are now no longer recommended outside of very unique situations because of risk of resistance. So the best first-line therapy is something that's going to suppress virus efficiently with very little risk of long-term resistance. And so when you look at lamivudine, our oldest agent, you can see that the risk of resistance to lamivudine was actually pretty close to 25% in the first year. That's important. And up to 70% by 5 years. Adefavir's was certainly lower, but still not acceptable. And tolbivudine is very similar in mechanism to lamivudine or emtricitabine, and so it really has the same risk to it. That leaves 3 agents, entecavir, tenofovir in the form of TDF or TAF. And entecavir has to be taken with asterisks, and that its resistance potential is higher in a person with pre-existing lamivudine resistance. So it's really only first-line therapy in a treatment-naive individual. If they have LAM-R, most of our guidelines really recommend a tenofovir-based product and not entecavir. Now, there are reasons to maybe not choose TDF, and that's because we're starting to recognize more renal and bone toxicity or signal with TDF, where we do not see that with TAF or entecavir. So if you have a patient who's over the age of 60, who's got chronic risks for osteoporosis based on chronic steroid use, fragility, pre-existing osteoporosis, or if has renal insufficiency defined as an eGFR less than 60, that's a pretty liberal definition, or albuminuria or low phosphate levels, or obviously someone on hemodialysis, then TDF is probably not your best choice, and you would want to pick one of the 2 other agents. And we can see that here when we look at TAF versus TDF, TAF being the dark line, TDF being the blue line, that there is a change in eGFR over time that is present in TDF, but not the other form. That is also true for changes in bone mineral density, where we see this both in the spine and the hip. There's less impact for TAF versus TDF. And I will show you a little bit if you have a patient who needs to switch an agent or has been on TDF and you want to switch them, that's, still has very supportive data. Part of this equation, though, is going to be monitoring your patients. And sometimes we're really good at monitoring, and sometimes we're less than ideal at monitoring. But when you think about starting a person on treatment, our goal is viral suppression, right? So we're all pretty good at monitoring ALT and hepatitis B DNA over time, because these are the 2 things that led us to initiate treatment. So these are going to be the 2 things you want to see normalize or become undetectable. It's also, though, important to monitor renal function. So often we're getting a CMP, we're getting renal numbers, and if you see an impact on your eGFR or phosphate, which is what is recommended, although not always on that CMP, you want to consider a switch to an alternative agent if your patient's on TDF. This monitoring is recommended for all of the agents, though, not just those on TDF, so that the algorithm is the same, the switch component is just a little bit different. And then lastly, our patients really do need to have liver cancer screening, although our guidelines do recommend starting that around the age of 50 in women and 40 in men, especially Asian men, or Black and Asian men, Asian women. Below those metrics, a lot of us still screen, but guidelines do absolutely tell us we need to start screening at 40 in men and 50 in women. And that's with imaging and plus or minus an alpha-fetoprotein. Now, I did already allude to this data. This was an important study where they started individuals either on TAF or TDF, and then at the end of a certain point, they bridged everyone to TAF. And you can see from the graphic on the right-hand side that those individuals in the light blue that were started on TDF did have some impact on their renal and bone function, but that essentially came back to the TAF arm once they were switched and monitored. So although this does not imply that someone who has had TDF for a decade has the same ability to bounce back to this level, it absolutely implies that, if we recognize something early and we make a modification, when we recognize it, we expect to see an improvement in bone mineral density and renal function. So stopping therapy. Every single one of our patients want to stop therapy, and I think this is an important conversation when you start. I tell my patients that this is like lifelong therapy. You should not expect to be able to discontinue. But there are some rules for discontinuation. The most robust is if you lose surface antigen. So surface antigen loss with or without surface antigen antibody seroconversion. Unfortunately, we just don't see that very often. We see it a little bit more often with pegylated interferon, which is our other first-line therapy if you find a well-chosen patient, but it is still not a common in vet. So although you could talk about that with your patient, and we should be monitoring for surface antigen loss, and actually now you can monitor surface antigen quantity so that that can kind of help you understand who might be able to lose surface antigen and who may not be able to lose surface antigen. We should not be telling our patients, yeah, we're going to watch for this and then we're going to stop your therapy, because that cavalier component is not going to be true for over 90% of your patient population. That doesn't mean that the rest of them are inevitably going to have to remain on therapy. Now, there are some rules. If you have cirrhosis or you presented with really decompensated, acute flare or something, we may not be we should not stop therapy. So it's only in a well-compensated non-cirrhotic individual who has been on prolonged therapy that this conversation can even start. And in an individual who has E antigen positive that then loses E antigen and seroconverts to E antibody after a period of consolidation. That means you can't just stop the therapy on the day that happens. You have to continue the therapy for at least 12 months, if not maybe longer. You might be able to talk about treatment discontinuation in that individual. You could also begin to discuss treatment discontinuation in someone who is E antigen negative, E antibody positive at the time of treatment, who has had a very long period of effective suppression. And this is, again, something that is not, there's a really high risk of replication if you stop therapy in these individuals, but not everyone starts to replicate. And so these are two groups where treatment discontinuation might be possible. It cannot happen in a cirrhotic, and it cannot come without effective monitoring. The most important thing is if you choose to stop someone, you can't just have them come back in a year. We don't exactly know when that risk of reactivation is over, but up to 2 years afterwards, people can start to replicate and need therapy again. And so they will have to understand that this is going to come with some monitoring to make sure we understand early if they're at risk for reactivation. So in our E antigen seroconversion, these are two different studies that kind of show you why a consolidation period is important. The first on the left was a study where patients essentially got a year of therapy, and those that seroconverted in the first 6 months obviously had more drug exposure than those that converted in the last 6 months. And so the more therapy you had after seroconversion, the more likely you were to have prolonged viral suppression after discontinuation. Now, what's not said in that study is that maybe it wasn't how much therapy you got afterwards. Maybe it was actually how quickly you seroconverted, and we're not going to know the answer to that. But the most important thing is we certainly can know how much treatment we give you after seroconversion, and so that's the component that we can control. The study on the right is a more inclusive study, and this study, although small numbers, this study actually looked at a group of individuals, and those that had over 18 months of consolidation therapy, so after seroconversion they received at least 18 months of therapy, their risk of reactivation was much lower, so that they were able to maintain their response at about a rate of 70%. And so many of us will recommend 18 months, not knowing if that's a magical number in these 21 patients, or if that was just something that was misrepresented in this small study. We also have other components, tools that we can use. Age and possibly gender are very important. So you can see from this, if you are over the age of 37, the risk of relapse or requiring therapy is going to be higher than if you're under 37. Making a more simplistic rule on the right-hand side, if you are over the age of 40 and you got less than 15 months of consolidation therapy, you had a very high rate of reactivation. If you were younger than 40 and you had more than 15 months of consolidation therapy, you had a durable response at a much higher rate. this is an important message, right? Because why did the European guidelines start to tell us to have this conversation about therapy with our patients when they were over the age of 30? It's because maybe delaying therapy until the ALT went up at the age of 42 or 50 robs them of an opportunity of seroconversion and discontinuation that we otherwise might not have given them. But we don't know that. The people in these studies all tended to fit the rules of treatment initiation. They weren't like an immune tolerant group that we were liberalizing therapy on. So I'm going to turn the last bit to the future of hepatitis B. And although everyone thinks that hepatitis B is so easy to understand, they love all those tables, it runs the risk of getting more complex. We are going to have some new definitions, we'll get that next, and we're going to have some new biomarkers. This is going to make med students and residents and fellows really cranky, but it's going to make clinicians really, really happy, because these are now tools that might allow us to have a surrogate for cccDNA, or a metric that might actually tell us if we can stop and start therapy. And so we might be looking at core-related antigen or hepatitis B RNA, like pre-genomic RNA, to help us with treatment decisions. And we are going to have new therapies. So our definitions, cure. We might be able to use cure for hepatitis B. But if we can't, we're going to actually use cure under quotation marks, right? Functional cure. So real cure means we got rid of every little tiny bit of hepatitis B in your body. Functional cure means that your hepatitis B DNA is not detectable. Your surface antigen is lost, and you have a decreased risk of liver cancer, but we probably didn't clear things like integrated hepatitis B or maybe cccDNA. A partial cure would be when you continue to have surface antigen, but your DNA is well suppressed off therapy. And even though we would love to have pure cure, these other two opportunities do imply that a finite therapy might be possible, which is what our patients would love. So just to review a little bit the hepatitis B life cycle, Hep B does a lot of heroics before it actually comes back out, goes in, comes back out, and we're going to concentrate on just a few of these areas. So we have a bunch of entry inhibitors. We already have them. We've had them for a long time. HBIG is an entry inhibitor, and we use it in transplant and for maternal to childhood transmission. But we also recognize that in the binding process, there's a loose binding, and then there's a more specific binding using the NTCP, and there are some inhibitors or substrates for that. And so this is something that might actually allow a binder to be used in someone who's got chronic Hep B as opposed to someone who's got a risk of exposure that we want to prevent. We also know that we might be able to drive at endocytosis, so even if you manage to bind, you shouldn't be able to actually get in and release, and there are mechanisms for that. Inhibition of cccDNA. So ideally, you would think that if you can suppress virus for very, very effectively, you shouldn't get any more cccDNA. But we know from our current NRTIs that that is not true, at least with our current medicines. And so there are two approaches. We could get better drugs to just suppress virus, or we might be able to rip up cccDNA. And one of the most interesting is the CRISPR-Cas9, which does genome editing, and this is not unique to Hep B. They're looking at this pathway for many, many things. But there is some concern when you can use it for many, many things that you might have some off-target effects. But it is a really exciting tool. And then we might also be able to target some of the other polymerase function, which could lead to less cccDNA or elimination of cccDNA. Well, if you get past that, you could also look at inhibiting gene expression. So maybe you get some genes that are actually produced, but if you can then lyse them or target them for clearance, then that's also very effective in stopping all the rest of the hepatitis B replication cascade. And so that they do have antisense nucleotides. That means like something kind of gets stuck on there, which targets it for destruction. We have ribozymes that can rip up the areas where you're actually producing your genes. And we have something such as RNA interference, or small interfering RNAs, which again tag things for gene expression to decrease the post-translational transcription. They are all very exciting, but again, a lot of these do have concerns for either delivery or off-target side effects. We have a tool that's a little more viral specific, and that's caspid assembly modulator, or a CAM therapy. So remember that the hepatitis B has to be packaged for release, and we can inhibit that packaging, or we can make the package empty. So these, in theory, would work in synergy with NRTIs, and may not be a curative strategy, but might be something that is very helpful for functional cure or long-term expression, lack of expression. So this is that idea. If you imagine that your protein dimers have to get packaged into the caspid, you can either, in a class 1 CAM, make your caspids all look kind of funky so that they don't get released, they don't look normal, or you could make them produced normally but empty. And so that's a class 2 CAM. And both of these things have been shown to be pretty effective and are very exciting. There's a lot of these in the pipeline. And some of them have class 1 and class 2 effects. Well, we know our traditional therapy are all reverse transcriptase inhibitors, NRTIs. So we've already tried to stick 2 of them together. That didn't seem to work that well. It didn't work any better than the most efficient one, and sometimes even worse than both together. When we think about lamivudine and tolivudine, they actually had less viral suppression when you threw them together than either one did on its own. We could try to stick them with pegylated interferon. We did that. We tried to do the PEG first and then the NRTI. We tried to do them both at the same time. We tried to do the NRTI first and then followed by the pegylated interferon. Is it possible that these tools were just not the right tools, but the mechanism, the thought, the science was good? Maybe. So there are a lot of these that are in development. What we don't know is whether they will be better than the ones that we currently have. Think about entecavir and tenofovir. These are good drugs. They are very effective. And so will these other, either tenofovir prodrugs or other similar class agents be better? We don't know that, but they are in development. So in conclusion, and there are many other things, I didn't even talk about the immune response, so that there is an entire other pathway of many, many agents looking at buffering, making the host have better immune response so that they can clear the virus, because a lot of this is like induced tolerance or immune laziness that leads to the persistence of hepatitis B. So therapy is still recommended for those with chronic hepatitis B, DNA greater than 2,000 and e antigen negative or greater than 20,000. Remember ALT abnormalities. Treatment is also now recommended for those at higher risk for progression in cancer, so a little more liberal. Medications with a high barrier of resistance are recommended as first line. That's entecavir, tenofovir, and pegylated interferon. And regular monitoring, irrespective of what you choose to do, whether it's monitoring or therapy, is essential. And lastly, we might be able to start to use the word cure. I am going to turn it over now to my good friend Eric Lawitz, who I still consider a Chicagoan, even though he's from TLI. Eric, I've not been to a conference where Eric is not one of the key speakers, so we all know him incredibly well, and looking at his CV would give me back strength. So congratulations.
Thank you, Nancy. It's always a pleasure to talk about hepatitis C. And you know, the discussion has changed in the last couple of years, right? For the last 15 years, I got up here and stood up and talked about SVRs, 3 or 4% differences, which therapy should we use, and really focused on combination antiviral therapy. The discussion now is changing, right? Because we've gone now from an era where we weren't sure what the effective antiviral strategy was to now having therapies that are universally successful with side effect profiles that are similar to placebo. So we'll have 1 or 2 slides on efficacy, and now the focus is on public policy, access to care, linkage to care, some of those important things. And now we just have to get these effective therapies to the patients, right? And that's the biggest challenge. The challenge is not the therapies themselves. The challenge is getting these effective therapies to patients. And we'll talk about the World Health Organization's small goal of global eradication. Just a small goal, right? Probably we'll finish that tomorrow. No, we will hopefully someday do that. We'll talk about that. Here's my disclosures. So hepatitis C, as we all know, is a big world problem, right? It's 130 to 150 million people across the world. There's certainly countries that have widespread epidemics. We talk about Cameroon, Egypt, and a few countries that have high prevalence of disease, but across most of the Western world, we have prevalence rates of 1 to 3%. In the US, there's about 3 million Americans that have hepatitis C, and obviously over time here it's decreasing. One of the big topics we've talked about for a long time is the underdiagnosis of hepatitis C and the need to increase screening. This slide dates back a few years, but at the time it was published, it was thought that 50% of patients who are still undiagnosed. We're making strides to improve these numbers, but still, unfortunately, relative to HIV and hepatitis B, hepatitis C is still underdiagnosed despite all the press and all the discussion we've had over the last decade. We all know why it's important, right? If you leave it alone, an inflammatory insult leads to progressive fibrosis, and neither the inflammation or the early fibrosis causes any trouble. It's ultimately the progression to cirrhosis, right? Once you get cirrhosis, we all know you're at risk for decompensation, hepatocellular cancer, liver failure, and need for liver transplantation, and that's what we need to avoid. So early treatment before cirrhosis, we know the liver fibrosis in the liver is a dynamic process, right? While you have inflammation, fibrosis is building up, but if we get rid of the inflammatory infiltrate, as I always tell the patients, your fibrosis can melt away over the years, and ultimately, if you're good to your liver and you eliminate hepatitis C, 10 years later, you could biopsy somebody who had F3 or even early F4 disease and potentially have normal livers a decade or 20 years later. So it's a really important tool to get rid of the inflammation, and this fibrosis will melt away until you get to some bit line in the sand. I can use the line in the sand analogy here since I just walked across the street and found a lot of sand, more sand than we have in San Antonio, but a line in the sand where you ultimately have probably irreversible disease, probably at the time when you develop portal hypertension. There is some point probably where it's going to be very difficult to reverse fibrosis. Ultimately, the new wave is looking at antifibrotic pharmacologic agents, so maybe someday we will have an antifibrotic that will even reverse the most cross-linked collagen that we have. Stay tuned. We'll hopefully present the antifibrotics in the next few meetings at EASL and ASLD. So the mortality rate for hepatitis C over the early 2000s was increasing. While all the other mortality rates for many infectious diseases were decreasing, we were still in an era in the early 2000s when ultimately the rate of deaths related to hepatitis C was rising. But guess what? Finally, with effective all-oral combination therapy, we've actually stopped the rise in rates of death, and we've peaked, and now we're actually starting to decline. This is rates of death in the US related to hepatitis C. Obviously, it's not a great marker because people tend not to fill out death certificates correctly. So if people die of liver decompensation, they put variceal bleeding on it, they never link it back to the hepatitis C, and they put liver failure. Unfortunately, we're not as great at looking at the underlying cause of death, so always these numbers are underrepresentative, but it does give you a trend to understand that no matter how it's recorded, the number of deaths are actually starting to fall now from hepatitis C. With the advent of being able to treat patients from mild disease all the way through decompensation, we're actually now positively impacting the rate of deaths related to hepatitis C. Isn't that's super important to people with patients with hepatitis C. So when we think about direct-acting antivirals for hepatitis C, obviously remember this is a curable disease. About 10 years ago, I was at a family practice conference in some major city in Texas, and I put in a audience response system question, said, what's the rate of do you think hepatitis C is curable? My answers were A, yes, B, no, C was only if you came to the Texas Liver Institute, and a couple other straggling answers. And you know, the number of people that responded hepatitis C was curable, this was about 12 years ago, it was 24% of primary care physicians answered unequivocally yes that hepatitis C is curable. We've come a long way now, all of you obviously know that, and most of the practicing doctors in the US know it. Over a decade, we finally taught everybody that hepatitis C is curable. Remember, it's an RNA virus, unlike hepatitis B and HIV, which are integrated into our DNA, and certainly Nancy was just telling us why it's so difficult to cure hepatitis B and certainly HIV, but hepatitis C, we had it easy, right? It's an RNA virus, it's not replicating the nucleus, and it was born to be cured, and we ultimately have now successfully done that. But even when we cure hepatitis C, remember that even though you'll have those antibodies that last a lifetime, are they protective? Will they protect you against hepatitis C reinfection? Yes or no? No, right, of course not. They're not neutralizing antibodies. They're great markers of previous exposure, but those antibodies aren't protective. So if you go back to the same thing that got you hepatitis C in the first place, you can get it over and over and over again. So my patient that was always memorable to me, I have a young girl who's come back 5 times with hepatitis C, every time she smiles at me and says, I'm not going to do that stuff again, I believe her, I treat her, she smiles at me, I smile at her, we're successful, and then a year later she reappears with hepatitis C, says, well, I didn't live up to my promise, but this time I really am going to do it. I'm not going back to that. I actually haven't seen her in a couple of years now, so I think she finally stopped. I hope she no longer has hepatitis C and nothing untimely occurred. So why does it matter if you cure hepatitis C? Because good things happen, right? Not only related to the liver. It's clear, I already told you, that if you cure hepatitis C, you have lower rates of progresses to cirrhosis. You have lower, even when you have cirrhosis, you eliminate or decrease rates of decompensation. You decrease hepatocellular cancer, and you have less liver deaths when you cure hepatitis C. But not only do we do good things for the liver, which makes sense, we actually do things for all-cause mortality, right? Remember, in 2012, Vandermeer published a very nice paper in JAMA that showed all-cause mortality improvement for hepatitis C. So not only do we do good things for the liver, we do good things for the entire person. All these extrahepatic manifestations that we haven't talked about a lot, but are important, right? You look at renal disease, hepatitis C influencing in the CNS, there's even cardiovascular benefits, of course, insulin resistance. I could spend a whole hour talking about extrahepatic manifestations, but with all these things, we do show an all-cause mortality. So curing hepatitis C is very important, not only from a liver-related outcome, but all-cause mortality. So you're doing great things for your patients by curing them from hepatitis C. So therapy. Normally I would have spent 19 of the 20 minutes on therapy. Now I'm spending 1 minute out of the 20 minutes on therapy because there's not a lot more to talk about, right? I can give you a history lesson. This timeline is really my whole career. Interestingly, I got into hepatitis C in the mid-90s and followed step by step as we went from short-acting interferon to long-acting interferon to adding ribavirin. The big landmark change in 2011, the incremental biggest change in therapy, SVR-wise, was the addition of first-generation protease inhibitor to interferon and ribavirin, telaprevir and boceprevir, which increased cure rates by about 30%, so a single high incremental change in efficacy results. But not only did it make efficacy results better, it also increased toxicity, and those were tough times, tough years to treat patients, right? We had the interferon side effects, we added the protease inhibitor, which weren't so benign at that time, and ultimately we had really difficult times of treating patients. Are all of you sad that you lost the ability to use interferon for hepatitis C? No, yeah, you guys are all happy you've lost the opportunity to use interferon. So what happened since the interferon era? We've gone to all oral direct-acting antiviral therapy, right? Initially, they were genotype specific, where we were using certain products for genotype 1 and other products for genotype 2 and 3, but and ultimately now increasing to 95% cure rates in those times. With the last few therapies, what's happened? We've gone to pan-genotypic. We have two kind of core regimens right now, right, that are pan-genotypic, and not only do we get above 95%, but we're pushing above 98%, so universal success. And we even have a salvage regimen, right? A 3-drug regimen that can salvage those DAA non-responders, which also has a 96% SVR. So as you think about it, the overall virologic failure rate is 2%, right? With whichever the two products you use today, it's about 2%. And if you can salvage 96% of those 2%, who's left behind? 1 in 1,000. So we're able to cure 999 out of every 1,000 patients we see with hepatitis C. Now you wonder why I'm not spending 19 out of the 20 minutes on therapies, because they're universally successful. And the side effect profile basically looks similar to placebo with what we have available today. So what is available today? You really have two core strategies. Both drug regimens have an NS5A, so that's common in the two strategies. The other component is either a protease inhibitor or a nucleotide polymerase inhibitor. So you're either using sofosbuvir as a nucleotide polymerase inhibitor or glecaprevir as a protease inhibitor in combination with an NS5A inhibitor. And the 3-drug regimen, which is a salvage regimen approved for retreatment. Salvage is a bad name, right? Retreatment sounds much nicer. Retreatment uses all 3 drugs, right? NS5A inhibitor, a nucleotide polymerase inhibitor, and a protease inhibitor. So we use 2 drugs with a common NS5A as core strategy in treatment-naive or non-DAA exposed patients, and then a 3-drug regimen for retreatment. So here are the 2 core strategies for your particularly treatment-naive patients. So you have sofosbuvir-velpatasvir and glecaprevir-pibrentasvir. They're common in a lot of ways. They're both pangenotypic. You can use them all both from F0 to F4. Duration is 12 weeks of sofosbuvir-velpatasvir. In treatment-naive non-cirrhotics, glecaprevir-pibrentasvir is 8 weeks, and cirrhotics is 12 weeks. And a very small percentage of patients are 16 weeks, particularly just genotype 3 experienced patients. Treatment-naive or treatment-experienced generally means non-DAA. It means interferon experienced. And in the middle box, you have sofosbuvir-velpatasvir voxiloprevir, which is for DAA experienced patients. Remember, that's the 3-drug combination, and in genotype 1 has a 96% rate of retreatment success. So I used to talk a lot about a lot of things that predict success. What was your viral load? What was your histology? I love talking about resistance. Those of you who listened to me for the last decade, I talked about resistance. Now I don't have anything to talk about because it's all 98% responsive, and it really doesn't matter what your baseline characteristics are. The therapy is pretty universally successful, and again, side effect that look pretty similar to placebo. So really the discussion has been minimized now, and we just have to shift access to care. Here's the overall success rates with both treatment regimens. This is not a head-to-head study. This is just reminding you that the high success rates across the 2 treatments. And what would you have thought? If I would have thought I was going to put this slide 10 years ago and saw all the hundreds up there, I would have thought I was smoking something funny, right? You would have never thought you were going to get to 100% in a lot of patient populations. But here we are. We're at a point where we have, again, 90, the low-hanging fruit here is 96 and 98. Everything else is north of that, and we have lots of hundreds across the spectrum. So no wonder we're shifting to access to care and linkage to care, right? So the therapies, once we get the patients on them, we get high cure rates. We just have to find the patients and get them linked to care, which is now the big struggle. It's the big topic, right? So if you go to ASLD and EASL, and the lectures are more on this topic than they are new therapies, because we kind of don't have any new therapies because there's not a lot more to prove. So there used to be special populations we talked about. Why did we call them special populations? Because they tended to have a lower SVR rate. So we kind of labeled them as special populations, be it HIV, end-stage renal disease, decompensated disease. Well, all these populations are not so special anymore. Now they respond just as well as anybody else. So we've not only eliminated baseline discussions on baseline characteristics, but we've also now kind of eliminated this term of special populations. In some of these populations, it is more prudent or labeled to use one drug or one combination over another. The dichotomy is, of course, in end-stage renal disease, where you don't want to use a nucleotide polymerase inhibitor, where it's not recommended with the GFR below 30, where you have a protease inhibitor with NS5A inhibitor with universal success, and in decompensated patients, you don't want to use the protease inhibitor. In decompensated liver patients, you don't want to use the protease inhibitor, you want to use the nucleotide polymerase inhibitor. So although in some of these special populations you do have a specific regimen that you should use, for the most part, the response rates are basically the same as they are in patients that are not so special, right? So everybody is not so special anymore. Everybody has equal success of therapeutic response. The only group we really haven't studied real well is that bottom group of pregnancy, which we don't want to do that because you can certainly treat them before or after they have their baby. No need to treat a pregnant woman at this point. So the hepatitis C problem is solved, right? Is it solved? Well, almost. Well, we have effective therapies, but we still haven't gotten them to everybody that needs them, right? So acute, and not only that, new cases of hepatitis C are on the rise. From the young people injecting IV drugs and the cheap heroin that's floating around, we have a new epidemic of increasing acute hepatitis C and that needs treatment. before we'll talk about acute hepatitis C, but I want to remind you some of the NHANES data. NHANES is the national epidemiology data. And this slide basically demonstrates the difference between HCV antibody positive patients and viremic patients across 2 different periods of time. On the left is 2003 to 2010, and on the right is 2013 to 2016. And that little arrow down represents the differential between antibody patient positive and viremic. So you can see prior to all oral direct antiviral combinations, 73% of antibody patients were viremic, right? Because we still had most patients who were untreated and still had hepatitis C demonstrated by HCV RNA. On the right, you can now see the impact of treatment. In 2013 to 2016, we've had effective all-oral combination therapy, and now you can see there's an increasing differential between viremic patients and antibody patients. So remember, once we cure patients, they're going to stay antibody positive, right? But their virus will be negative. So you're going to see a smaller percentage of patients being HCV RNA positive. So this really shows the impact of treatment, that we've really started to have effectiveness of wiping out patients who are viremic, of course, still maintained antibody positivity, but that transition from 73% of patients being viremic now to 57%, hopefully that number will continue to rise in the number of patients who are differentially viremic versus antibody positive, i.e. a lower percentage of patients with viremia despite everybody still being antibody positive. So what are some of the changing trends in hepatitis C? Well, the young people are the new epidemic, right? It's the IV drug users, and each line here represents an age cohort with the top lines being the younger people. You can see 20 to 29 and 30 to 39, and the darker orange and yellow lines are increasing over as the years go. Now the new cases of hepatitis C are all young people giving HCV RNA to each other through, unfortunately, IV drugs, and that's really the new burden of new hepatitis C. So we have kind of 2 burdens of hepatitis C, right? We have the baby boomers and we have the young people injecting drugs. Baby boomers with the blood supply was a big issue, especially prior to 1970 when we had paid volunteers. It started to decline once paid volunteers went away. Then another decline in the hepatitis C in the blood supply came in the mid-'80s when some mysterious virus popped onto the scene. What mysterious virus was that in the mid-'80s that was discovered? HIV? Yeah, right, HIV. HIV came onto the scene, and that actually, before we discovered hepatitis C in 1989, that decreased the prevalence of non-A, non-B hepatitis in the blood supply. And then on the right are people who inject IV drugs, and prevalence rates, depending on where you look in the literature, anywhere from 30% even up to 90%, depending on where you look. So there are some areas in the country that are more vulnerable to hepatitis C outbreaks. These are in the green. Anybody admit to being from any particular part of the green dots? Is that anybody's hometown? No? Oh, there's a hometown. Okay, there you go. And she's even admitting it. That's good. So what are the risk factors in these parts of the country? Unfortunately, these are places where unemployment rates are high, overdose deaths are high, and prescription opioid sales are high, and certainly increased risk of IV drugs. I don't know why. We have to ask our consultant there in the back row who admits from being there why that would be. Hopefully it's not that there's nothing else to do, but we'll talk about that after the meeting. So when we talk about epidemiology of hepatitis C, we're creating this double hump. So on the left, 2005, this was a baby boomer classic bell-shaped curve. And as we move over to the right, we can see as time passes, the young people are starting to create this double peak, right? So we have a peak in the young people in their late 20s, and then the peak in the baby boomers. So we've gone from this traditional bell-shaped curve to a double-peaked epidemiologic pattern of hepatitis C. So here's the World Health Organization. They have this small goal of worldwide eradication. So they want to put it the same way as smallpox and get rid of it from the world. And I certainly hope and pray that the day I take my last breath that the World Health Organization is right and hepatitis C is eliminated from the world, and I will feel like certainly a career went very, very useful in helping in my small piece to get rid of hepatitis C from the world. But certainly we hope that we can occur, and it would be lovely in my lifetime, but we'll see if that happens. I plan on living to be a very old age, so I may need it if I need to get rid of hepatitis, if we're going to accomplish that goal. So, although eradication is a lofty goal, the World Health Organization wants to eliminate hepatitis C as a major public health threat by 2030. Well, that's a little bit of a more modest goal and reasonable, right? So here's the things that they would like to do by 2030. They're across the bottom, have 90% of people infected with hepatitis C be diagnosed, so get rid of that undiagnosed big cohort of people, have 80% who are diagnosed treated, have 90% of people access to the hepatitis B series, have 100% of blood products safe, and have 90% of injections in healthcare facilities safe. I'd rather see that at 100%. 10% of injections in healthcare facilities certainly don't want to be unsafe. So here's where we are as a goal. Who's on track for 2030 in the US? Which states are on track? Which states are not on track? The states that are on track for 2030 are in the blue. Look hard, you can't find too many of them. Bob Brown's from a state here where he's one of the few on track. He's your next speaker, and probably from the state of New York, where they're one of the only states on track for eradication, or at least this 2030 treatment. Here in my state in Texas and here in Florida, we're on similar trajectories, 2050. And everybody in the gray there, and Nancy from Illinois is even worse than Texas and Florida. So unfortunately, as a country, we have to do a lot better to get on track, right? We're going to have to diagnose and treat more effectively. One of the reasons we're all having trouble is Medicaid, right? Medicaid is a huge population that have patients, and depending what state you're from, some Medicaid programs, many have restrictions. There's 3 key restrictions that can occur: fibrosis, sobriety, and prescriber. So in Texas, we still have to be F3 or F4 to treat patients. And you still have to have a negative drug test, and you have to be a treater, ID, GI, hepatology. So you can see Texas and Florida here are vying right in the red, in the bad part. 32% for Texas treated, 34% for Florida. So I guess Texas and Florida are linked here a little, but you guys have had more success here in decreasing restrictions than we have in Texas. So hopefully these numbers will change as restrictions have been improved here in Florida. They still haven't been touched in Texas. We need more. We don't need more lawyers in Texas. So maybe more lawyers targeting Medicaid. I know they're outside my office there's signs, bulletin boards from all the lawyers that love to talk about many things, but not suing Medicaid, which is interesting. So shifting, before I get myself into trouble, I better get off that topic, because sometimes I don't know what comes out of my mouth. I say it and say, should I have said that? But anyway, so before something else that random comes out of my mouth, let's shift to prisons. Prisons, are an interesting area where we can effectively treat patients for hepatitis C. There's 10 million people that cross the prison population each year, and about 30% of the country that has hepatitis C has spent some time in prison. And about 1 million people are in the prison at any time. So there's an opportunity really if you're going to take a big chunk of hepatitis C and eliminate it, wow, this is a huge target, right? We could really do a major step forward if we could access all these prisoners and get hepatitis C obliterated from the prisons. And we're really going to contact, again, 30% of people in the US have hepatitis C go through the prison system. That's huge. If we could get them treated and cured, they won't give it to others, and that would be an amazing step forward. Unfortunately, we've got a lot of work to do. If you look at states that screen for hepatitis C on the right, the yeses in the darker color are those states that where there's prison screening. Unfortunately, there's too few dark colors and too many light colors where there's no screening. We need to improve that. And treatment rates are miserable in the prison. No one wants to pay for it, and no one gets treated, right? So there's very few states that have anything more than a nominal rate of treatment in the US. So we all know that the testing, unlike Nancy's hepatitis B talk, where all this antibodies and antigens and all things to talk about, here we just have a simple antibody test, right? Is it positive or negative? And you verify that with HCV RNA. If you have HCV RNA, you need treatment and cure. If you don't have HCV RNA, you're good to go. Linkage to care is a big topic. The only point of this slide is going all the way from the left to the right. If you end up looking at people who are young and drug users, the number of patients that actually get treatment is very small, and especially if you're under 35, all the way to the right, 8% of those that are diagnosed end up on treatment. So not only do we have two big issues, we have to identify the undiagnosed and link every single one of those diagnosed patients to treatment. If we do that, we're well on our way ahead of where we're not now. So overall management, what should you do in your clinics tomorrow? Well, tomorrow's Saturday, so you won't be there, but what should you do Monday when you get to your office? Make sure your hepatitis C patients abstain from alcohol. Make sure that they don't have concurrent other liver disease or infections, HIV, HPV, NASH. Stage patients, you have to make sure patients, the big question only now is if patients have cirrhosis or not, and if they do, we need to do HCC hepatocellular cancer screening, get them vaccinated for hepatitis A and B and pneumococcus if they're cirrhotic, and educate them on their disease. You guys all know by now there's a living document on the IDSA ASLD guidelines that changes with any change in therapy as a guidance document that's available online and is very fluid and changing. And hopefully we'll decrease prevalence by increasing, we have high rates of cure, we just need to keep people from being infected, and we should decrease our prevalence. So takeaway points, we have a highly effective, safe treatment, over 95% success, not only above 95, really above 98% success rate, and adverse events profiles that are similar to placebo. We need to take important steps now on, what did I say, identifying the patients and linking them to care. It's not, are the drugs effective enough, it's how do we access the patients and how do we get them connected to care. I talked about prisons. 30% of people with hepatitis C in the country have been in prison at some point. So if you have a patient who's ever been in prison, that's certainly a patient we should be screening in addition to any other risk factors, the birth cohort and risk factor-based screening. Global eradication won't occur without linkage to care, and so that we need to get all these patients into a hepatitis C treater. And if they have cirrhosis, don't send them away and say, I'm done. We need to HCC screen them. Hepatocellular cancer, right now people are starting to talk about it as a kind of, I have a virus, I have a drug, give them the drug, they get rid of the virus, and people are starting not to evaluate the liver. They're forgetting to check for cirrhosis because now we have drugs that work and you just give them and they forget to evaluate extent of disease. The problem with that is the patient's all happy, you get hugs, you get cookies. In San Antonio, we get tortillas and cookies and all sorts of things when we cure patients. And now we have tortilla toxicity. I think somebody's going to talk about NASH somewhere along the way. So everybody gets excited when they're cured, but if they come back 5 years later with an HCC, they take away the cookies and hugs, and now you get a subpoena from the lawyer saying, why didn't you check for cirrhosis, right? So we need to make sure we check for cirrhosis. With that, we're going to turn it over to Robert Brown, who, again, is well known to you guys, internationally recognized hepatologist from Cornell, who's been on the leading edge of anything new in hepatology for a long time. Always great to have you speak.
Thank you. Greetings from the greatest city in the world. In the next 30 minutes, I'm going to go through some of the complications of cirrhosis. We're going to focus today on encephalopathy and thrombocytopenia. If I had an hour, I also would have done ascites and variceal bleeding. So with half the time, we chose half the topics. Or less if I can't make the slides move forward. Maybe a different button. Let's try that one. There we go. Those are somebody's disclosures, not mine. I don't even know what Canadas is, but mine are available someplace. Whatever. They're probably my sister, Kim Brown's So let's start with encephalopathy. We know that discharges from our hospital are increasing, and we know that the discharges from our hospital are changing. When I was younger, we admitted patients for a lot of GI bleeding. That was the most common consult we got as gastroenterologists. Now almost everyone gets admitted for ascites and its management and complications, and encephalopathy and its management and complications, and they tend to go back and forth. We over-diurese them, they get encephalopathic and AKI. We hydrate them, they come back in because they couldn't get a tap in time, and we'd have to tap them in the ER. And they've continued to increase since 2011, though the data is not yet available. And of course, as a big part of that, you see increases in hospitalizations for patients with HE. Because once you have one admission for HE, you're likely to have subsequent. And increasingly recognized is that HE by itself is an adverse prognostic sign. HE is the only symptom that defines liver failure. So acute liver failure is acute liver injury with encephalopathy. Chronic liver failure, it requires the presence of encephalopathy. And the reason that encephalopathy is so horrid is that portal hypertension or high resistance is not, your liver can still compensate. When the degree of shunting, portosystemic shunting, becomes so severe that you're encephalopathic and require hospitalization, outcomes are poor. So at that first presentation of encephalopathy, you don't tell most of your patients you have a 50% one-year survival. You better figure out how to get a liver transplant. And if you have a low MELD and encephalopathy, you're going to have to think about a living donor or something, because your likelihood of being around the next 2 to 3 years is unlikely. And not only are you unlikely to survive, during the time that you are waiting for death or transplant, you're going to have poor quality of life. And so this was a study from Jaz Bajaj at VCU, in which he looked at the things that are happening to people who have encephalopathy. One, they tend to have trouble working. So financial impact, stop saving, in debt. They can't pursue education. They have trouble with bankruptcy, food, getting evicted from their home. None of those are a desirable outcome. And hopefully, if you improve mental functioning, you will decrease the impact of this. And if you want to get a little more precise, you can measure quality of life with numeric measures. So you can see the blue line are the US norms. The line below it, which is orangish, is people with cirrhosis who don't have HE, and their quality of life is impaired. But even if you have minimal HE, which is only diagnosed with neuropsychiatric testing, none of us would find it on our clinical exam in the office, you see another diminution even when you are back in remission. And as a matter of fact, the impact of minimal HE on quality of life is almost the same as those that have overt HE in between their episodes. Obviously, during the episode of HE, they have probably poor quality of life but don't know it because they're too confused. That was a joke, perhaps. Poor one, I'll accept, but it was. Either that or you're encephalopathic and didn't notice the joke. So when patients come into the hospital with HE, we spend a lot of money on them. Some of it probably important, a lot of it unnecessary. They get serial irradiation of their heads to get CAT scans each time they come in, a lot of lab tests, maybe paracentesis, antibiotics, and then lactulose and other therapies. And we've seen that the number of the charges with that and the number of procedures keep increasing. And that's measured in a cost increase over that period of time, which is about 50%. $35,000. That's cost, not charges. The charges obviously are longer because no one gets charged only $35,000 for 6 days in the hospital. My wife got charged $2,000 for a nasal swab for flu and respiratory pathogens. How many patients do I have to see to charge $2,000? I should be a nasal swabber. Many of these involve a short ICU stay, and those patients also have an increased risk of death. And once they leave, they have about a 1 in 5 chance of ending up in a nursing home. And that not only contributes to cost, obviously does not improve anybody's quality of life. And then once they go home, you know what happens, they come back. As a matter of fact, up to 15% within a week, which you know looks bad on your report from your hospital. 48 hours even worse. And then another third will be admitted within a month, and if you followed them over a period of time that was less than 1 year, about 70% come back in. They don't just come in for HE, they come in for ascites, for SBP, for variceal hemorrhage and renal failure. On average, they come back in less than 3 months, and it's not only once. The average number of readmissions was 2, and the median was 2, the mean was 3. And as you can see, recurrent HE is the largest reason that they get readmitted, though the other causes are also important and need attention. And if you look at the risk factors for readmission of the portal hypertensive complications, so you can see ascites, variceal hemorrhage, HE, hepatorenal, and hepatocellular carcinoma, the largest risk factor for readmission is HE. In part because it's so recurrent, in part because it's either difficult to treat or we undertreat it. And if you look over time, patients who are readmitted get readmitted pretty frequently and have a high cost. And you can see the costs here, readmission associated with far more cost than the primary admission. You can see on the left the primary admission cost, and then those that get readmitted, marked increase in cost. But if you can prevent readmission, subsequent costs go way down. So preventing the first admission is good, but more importantly, preventing readmission is critical. So how do we do that? We do it by providing therapy and providing it correctly. Lactulose and rifaximin are the only 2 drugs you really should be using in the management of HE. They're the only 2 FDA-approved regimens. Neomycin, metronidazole, and vancomycin oral should not be used. 1, because they're not approved. 2, because of the risks of long-term use. Many people know about the renal effects of long-term neomycin, but many people underestimate the risks of long-term metronidazole. But anyone who's used long-term metronidazole will have patients complaining of peripheral neuropathy, which then becomes permanent. So what about lactulose? Lactulose is our first-line therapy for acute HE. It causes an improvement in 70 to 80% of patients. Its mechanism of action is multiple-fold. 1, it's fermented in the colon. That fermentation acidifies the colon, turning ammonia to ammonium, NH4+, which prevents its absorption. It actually changes the gut bacteria, which will preferentially metabolize disaccharides over proteins and decreases ammonia production. Its least important effect is the cathartic effect, though it is the one most loved by residents and often PAs who think a little lactulose good, more must be better. It is universally hated by the nurses who know that a lot of lactulose is a pain in everyone's tushy. So the goal is really, I set as my goal 2 bowel movements. I'll tolerate 1 soft or 3, but not more. And I don't use more than twice daily dosing because in someone who's confused, compliance is an issue. And telling them to take it 4, 5, 6, I've seen 6 times a day. Now, if you have a meticulous caregiver who wants to titrate the lactulose like a scientist, fine. But for most patients, twice daily dosing, small changes, and tell them to aim for 2 soft, not watery stools per day will help. And that will decrease the side effects of bloating, cramps, etc. Because as you metabolize lactulose, you produce methane, and you have no choice. And so the more you give, the more gas you'll get. And then people will stop taking it, and once they stop taking it, they'll get readmitted. Now, rifaximin is, I guess, the newest agent approved, but not new anymore. And I don't even know why I have to still educate people on the use of rifaximin, but it is still underutilized. It is minimally absorbed. It has broad spectrum activity, no drug-drug interactions. Because it's not absorbed, you don't have to dose adjust no matter what the severity of liver or renal disease, and it's approved for recurrent HE in adult patients, and usually used with lactulose, because in the registration trials, almost everybody was already on lactulose. So in this trial, when you look at the placebo arm, you can think of that as lactulose monotherapy, and you can think of the rifaximin arm as rifaximin plus lactulose, because 91% were on it. And they were followed for 6 months after 2 episodes of HE while they were in remission. And if they made it through that time and were still doing okay, they went into an open label maintenance phase with prolonged rifaximin. And in that trial, we saw a 50% reduction in breakthrough HE and a 50% reduction as a result in hospitalizations. And since we saw that readmissions drive cost, earlier utilization of combination therapy is likely to be cost savings. But what happens is we use it in the hospital, the patient gets discharged, they go to the pharmacy and the copay is high or whatever else, they don't take it, they don't call you, we don't follow up, and next thing you know, they're back in the hospital. But if you look at use of rifaximin, it is associated with fewer hospitalizations and fewer days in the hospital than lactulose alone, part because it's more effective, part because people are more compliant. And of course, if you have fewer hospitalizations, you have decreased cost. And it is very safe. One would think that ongoing use of a oral antibiotic may be associated with C. diff, resistant infections, etc. But you see, because this doesn't totally obliterate the gut microbiome, the event rate is very low. During the randomized placebo control arms, you can see the number of adverse events, placebo and drug were the same. The subsequent adverse events were actually lower, but that is probably just because if the patients made it past that time, they were more stable, because actually 10% of the patients died during the 6 months and thereafter because the presence of encephalopathy is a bad prognostic sign. So in summary, HE is associated with morbidity and mortality, a significant cost, and rifaximin use to prevent recurrence, promote remission, is part of your armamentarium along with prompt referral for transplantation. So now I'm going to turn to something newer, more exciting, well, not more exciting, newer, and that's thrombocytopenia. Thrombocytopenia is probably the most common sign of early cirrhosis or portal hypertension. It occurs in 70% of people with chronic liver disease and gets worse the more portal hypertension you have. If you have low platelets, you're going to either not have treatments or perhaps have diagnostic tests when you could have therapeutic tests. or have increased risk of bleeding when you have it. The risk of mortality parallels the low platelets, not all of it due to bleeding, because platelet count is a measure of severity of portal hypertension, and severity of portal hypertension predicts outcome. So where does it come from? When I was young, I was taught it was about splenic sequestration. Blood can't get through liver, backs up into spleen, spleen gets big, platelets get caught, that's it. But there are other things, and we've learned that one of those factors is TPO, or thrombopoietin, which is made by the liver, is too low for the given platelet count. Just like in renal failure, EPO levels are too low for the given hemoglobin. And so if we think about thrombocytopenia in chronic liver disease, patients require procedures, banding, tapping, thising, thatting, dental extractions prior to transplant, and those procedures have differential risk, and then we have differential tolerance of that risk. Some of us just tolerate the risk, some of us don't do the procedures, and some of us do the procedures and fret a lot. But all of us would be happier if the platelet count was higher. I haven't met a single person who said, oh, I'm always happy when my patient who I'm doing a colonoscopy has a low platelet count because it's like doing the triple twist on the diving board. I like to increase my degree of difficulty. You don't get extra points in colonoscopy for increased degree of difficulty. You only get Surus. So then why don't we just give platelets? Easy fix. Well, it's not an easy fix. We all know that. It doesn't work. So what are the guidelines that guide us? Well, the answer is they're pretty poor. One, they're pretty vague. And two, most of them were made not for liver disease patients, but for bone marrow failure patients. So those patients getting chemo or other things where the platelet count is low because of lack of production. But the guidelines, if you look overall, somewhere around 50 if you're going to do therapy. The strangest one is the ASGE, which says if the platelet count's 20, you can look, but you can't touch. It has to be 50 if you're going to do anything. So then you have to decide, am I going to try to get it above 50 so I can do something, or am I going to do it at 20 and then bring them back and do it again at 50? Depends on your morality and your desire for extra procedures. But 50 seems to be the golden number. And as I said, in CLD patients, based on basically zero data. But why are guidelines important? Well, guidelines are important because if you have an adverse event with a platelet count under 50,000, your risk is higher than when you have an adverse event and your platelet count is above 50,000, because that's what the guidelines say. And that's why you have to know them. But I can't tell you that 45 is substantially higher risk than 55. So what are the considerations for platelet transfusions? Well, the thought would be you'd decrease the risk of bleeding by increasing the platelets. Now, if someone is actively bleeding, I agree, you should use platelets. But to prevent the risk of bleeding, it's not so clear that they do it, because in patients with chronic liver disease, they have a very short duration because they get sequestered in the spleen, just like the patient's native platelets. And over time, you get immune and non-immune refractoriness. And many of our procedures, the risk of bleeding is not just at the day of the procedure, but a week later. We see post-polypectomy bleeds, banding ulcer bleeds, certainly more than a few days to a week after the procedure. Not to mention pain in the ass to organize, and if you're doing an early morning procedure, nigh on impossible. And if the anesthesiologist wants to get a platelet count after you give the platelets, it's a whole day procedure. So I'm going to talk about the two relatively newly approved agents that can be in addition to your armamentarium should you choose to use them in raising platelets in your CLD patients prior to procedures. They are both TPO agonists. Avatrombopag we'll talk about first, but both of them mimic the effect of TPO. They are non-competitive in activators, so they don't compete with TPO. They add to TPO, and they have a pretty predictable effect of increasing megakaryocyte numbers and maturation and increasing the platelet count. The study designs for the two studies are quite similar, but have some differences. So for the avatrombopag, the two studies were called ADAPT-1 and ADAPT-2. Both of the registration protocols took CLD patients with platelet counts less than 50. For avatrombopag, they were stratified based on less than 40 or 40 to 50. And they have two different doses of avatrombopag at 60 and 40. So the higher platelets get 40, the lower platelets get 60. Both of the treatments are 5 days. You then wait, and the procedure is done on between days 10 and 13. So 5 to 9 to 8 days after the completion of the 5-day treatment period. And then the patients were followed for about a month. The endpoint was not needing platelets and not bleeding, because obviously if you didn't get platelets and then you bled, you're really not a success. And then who got over 50 and what was the overall change in platelet count, and obviously safety. And you can see that despite the lower dose, the patients between 40 and 50 are overwhelmingly likely to get above 50, not require a platelet transfusion, which was mandated if you weren't above 50, and not have bleeding. You can see that some of the patients in the placebo arm didn't get a platelet transfusion and didn't bleed. But if you look at the proportion that get above 50, very uncommon if you were under 40 with placebo, and only about 1 in 5 got to above 50 in the placebo arm. And here is what you really want to know is what happens to the platelets. So you can see that on average you can expect a doubling. So the less than 40 was started at 30, they went to about 60, the 40s went to about 85, and then they stay up for about a month, giving you not only your procedure time, but one, a little wiggle room if something gets moved, and post-procedure protection where the platelet count gets back down to baseline by about day 30. And the side effect profile of this agent was basically the same as placebo. There was no increase in thrombotic events and no real increase in any side effects. Lusothrombopag was approved shortly thereafter. Very similar design in that it was patients with a platelet count under 50,000 who are going to have a procedure. Here the dosing is a little different. It's 7 days, a single dose, 3 milligrams per day, compared to placebo. The procedure done once again between days 9 and 14, and then up to 35 days of follow-up. Once again, platelets were supposed to be given if the platelet count was less than 50 on the day of the procedure. And the primary endpoint, basically the same. No platelet transfusion, no rescue bleeding, and what are the platelet dynamics and how long did they stay there? And what you see is very similar results. About 2/3 of the patients not requiring rescue therapy and not requiring a platelet transfusion. Similar numbers of those getting above 50,000 and an increase of more than 20. It's impossible to compare the numbers relatively because they're not head-to-head trials. The study populations were different, and there's this non-stratified analysis for LUSU and a stratified analysis for AVA. But what you see is pretty similar because when you look at the platelet dynamics, once again what you see is a doubling of platelet count. It stays up during that period pretty consistently from day 9 to 14, and then that slow decline back to the baseline platelet count by around day 30. So if you want to slip in a second procedure, you can do that during the tail. And once again, no increase in clotting. They look particular at portal vein thrombosis, and you can see 1 PVT in LUSU, 2 PVTs in placebo. So either placebo causes PVT or portal vein thrombosis, or there is no relation. And obviously it's a numerically higher but not statistically significant increase in bleeding events in the placebo arm. So, in summary, though I didn't tell you this, why? Liver disease does affect all aspects of clotting, including hemostasis, coagulation, and fibrinolysis. And though I will tell you the most important factor here is fibrinolysis. So if you're going to measure one clotting factor, fibrinogen should be measured routinely as your risk of bleeding and should guide your supplementation accordingly. Cryo is probably more important in a bleeding cirrhotic than FFP. Not on your post-test, fortunately. Decreased clotting factors are associated with decreased anti-clotting factors, so patients can also clot. And so the idea that a cirrhotic with an elevated INR can't develop a DVT is wrong. We don't really do a very good job with our conventional tests of doing this, but thrombocytopenia is a clear relation to bleeding risk, and we now have new agents to help us with that. Thank you very much. And I'll turn it over to Dr. Alkhouri, who also comes from Texas. You'd think it was a big state, who's going to talk to us about PBC.
Thank you. It's good to be here. Thank you guys for coming. So my task today is to tell you about PBC, screening, diagnosis, and treatment. This is some of my disclosures mainly related to doing clinical trials in the NASH space more than PBC. So I want to start with this slide, and I want to leave you guys with this image of a patient with PBC. And I want to take my time, but this is your classic patient that has PBC. It's typically a Caucasian female, middle-aged. They present typically without any specific symptoms, sometimes fatigue, mild itching, and they have elevated alkaline phosphatase. And you can see that, she's touching her eyes because she has dry eyes, okay? And this is what we call the Zika complex. So I always ask my patients with suspected PBC, elevated ALK phos, do you have dry eyes? Do you have dry mouth? This is classic for PBC. Sometimes they have a lot of also cavities because they have dry mouth. So this is a classic patient with PBC, and if I see a middle-aged female with elevated ALK phos, it's PBC until proven otherwise. Okay, so please have a high threshold to suspect this and diagnose it. So what is PBC? It's a chronic cholestatic liver disease, which means that typically it presents with elevation in ALK phos, gamma GT, bilirubin. It's autoimmune in nature, so your own immune system attacks the intrahepatic small bile duct, and it affects predominantly middle-aged females. So if you look at women above the age of 40, it's actually not a very rare disease. So it's about 1 in 1,000 to 1 in 2,000. Okay, so this is the most common autoimmune liver disease in middle-aged women. And it seems like recently there is a rising incidence and prevalence in PBC. So these are the main clinical features of PBC. Typically fatigue is the most common symptom, and the fatigue is very severe. So they tell you, I just cannot get out of bed, I'm about to lose my job, and it does not correlate with the severity of their liver disease. So we know that all patients with cirrhosis have fatigue, but in PBC, it doesn't really correlate it with the presence of cirrhosis. They have severe fatigue. Pruritus is a common symptom also that happens in about 50 to 60% of patients with PBC. Typically, they have other autoimmune diseases, and this is very important to ask about. Probably the most common one is autoimmune thyroid disease, and actually we should always check a TSH level in our patients with PBC. I do it on a yearly basis because the prevalence of thyroid disease is high in patients with PBC. Sometimes they have other autoimmune diseases. I test for celiac disease. Many patients have lupus or rheumatoid arthritis, Sjogren's syndrome, so always ask about other autoimmune diseases in the patient and in the family. They tend to have also decreased bone density. This has to do part of it with fat-soluble vitamin absorption, especially vitamin D. So you need to do a DEXA scan at baseline in every patient with PBC, and then depending on the results, but if they have a normal baseline, then repeat every 3 years. High cholesterol is common also. Typically they have high HDL cholesterol, which is good cholesterol, and this has to do with the fact that actually we make bile acids from cholesterol, and when you have a cholestatic liver disease, you have this feedback to decrease the synthesis of bile acids, so your cholesterol goes up. Back in the day, we used to see more of these xanthomas, which is typically related to having very high cholesterol levels, but I haven't seen xanthomas in a PBC patient in a couple of years now. So the disease is an autoimmune disease, but you have a genetic background that predisposes you for PBC, and actually it runs in families. So always ask your patients if, a sister has PBC, mother has PBC, and we see it cluster in certain families. There's definitely an environmental predisposition, and you see a picture of E. coli here as the bacteria, because there's this theory that maybe PBC is related to recurrent UTIs, and maybe that's why it's more common in women, because they tend to get more UTIs than men. There are many theories about why PBC is more common in female patients, including potentially nail polish, makeup. There's certainly a geographic distribution also in PBC. But anyway, you have your genetic background, you have the environmental exposure, and that triggers the immune system and the immune response, and you start seeing this inflammatory destruction of the intrahepatic bile ducts. So PBC starts with the development of these autoantibodies we call AMA, anti-mitochondrial antibody. They mainly target an enzyme in the mitochondria called pyruvate dehydrogenase, so this is the first step. And then that leads to, again, the immune system attacking the intrahepatic bile ducts, the loss of the intrahepatic bile ducts, and this is when you see your alkaline phosphatase, gamma GT start going up. This leads to damage to the liver and the development of liver fibrosis, and over time, a certain percentage of patients will end up with cirrhosis, potentially portal hypertension, and you see your bilirubin starts going up when you have more advanced disease. One important point I want to make is that about 1% of the general population may have a positive AMA. So if you end up, getting just a report that the AMA was positive because they saw a rheumatologist and they just tested for it, but the alkaline phosphatase is normal, it doesn't mean that they have PBC. So you need to have, evidence of cholestasis and then have positive AMA. So to diagnose PBC, you need to have unexplained elevation in alkaline phosphatase, typically more than 1.5, the upper limit of normal. Upper limit of normal in our lab is 120, so I say 180 is a good cutoff to remember. You test typically for the AMA antibody, and if it's positive and you have elevated ALK phos, you have your diagnosis. And if you do a liver biopsy, you see this collection of inflammatory cells. This looks like a granuloma attacking a bile duct. So this is what we call a florid duct lesion, and you would get this in the pathology report. And sometimes they tell you also they see granulomas. So if you see granulomas on a liver biopsy report, PBC is part of the differential diagnosis, in addition to other things like sarcoid and certain infections. So again, if you have a female patient with elevated ALK phos, positive AMA, you have your diagnosis of PBC. You do not need to do a liver biopsy. Back in the day, we used to do biopsies to stage the disease and see how advanced it is to determine the severity of fibrosis. But now I routinely use my FibroScan machine, which measures liver stiffness to determine the severity of disease at baseline. And I'm assuming that everyone has access to a FibroScan machine in the room. Yes, you guys know what FibroScan is? Okay, perfect. This is good, because a few years back it used to be a novelty, but now everyone knows about FibroScan. So this is an algorithm from the ASLD to tell you how to work up someone with elevated alkaline phosphatase. And the first thing you have to do is ask about other chronic liver diseases, including excessive use of alcohol, use of IV drugs. But then you need to do imaging, and typically you start with an ultrasound to exclude biliary obstruction. So this is something that you should be able to see on an ultrasound. Sometimes you have to do an MRCP. Then you do your autoantibody testing. You can check your AMA for PBC, and then you can check the smooth muscle antibody, ANA, to check for autoimmune hepatitis. And if in doubt, you can do a liver biopsy, especially if you have someone with a mixed picture. They have very high alkaline phosphatase, but also very high AST and ALT, because some people can have overlap of PBC and autoimmune hepatitis. So when the diagnosis is not clear, or if you suspect overlap, a liver biopsy is helpful. We have some what we call variant syndromes with PBC. So about 5% of patients with PBC will actually be AMA negative. So they have high alkaline phosphatase. It's your classic patient, female, who's 45 years of age. And then you test them and the AMA is negative. And these are the patients I would do a liver biopsy, but we also have other antibodies, special kinds of ANA antibodies. We call them GP210 and SP100 that you can test for, and they could be positive in AMA negative patients. So this is what we call AMA negative PBC. As I mentioned, you can have overlap with autoimmune hepatitis. Typically, they have also very high ALT, AST, high immunoglobulins, and you can have both diseases, and you actually treat for both of them separately. And then there is a variant called the premature ductopenic variant. This is a very aggressive form of PBC that progresses very quickly to cirrhosis and typically portal hypertension. So when you diagnose someone with PBC, how do we treat? The first line treatment is ursodeoxycholic acid. This has been the first line since I think it was approved in 1997. So we've had it over 20 years. It's a bile acid. It's actually a naturally occurring bile acid, and we dose it 15 milligram per kilogram daily, and I do it BID. I've seen patients come TID and QID, and there is no reason to do this unless you want to torture your patients, so just do it BID. Okay, because it's much easier to comply with twice daily dosing. And URSO actually works, and typically you would see the effect within 6 to 12 months, and it works in about 60% of patients where you achieve the optimal outcome. And the way we monitor response to URSO is by looking at the alkaline phosphatase, and the goal is to bring it to less than 180. Okay, so this is less than 1.5, the upper limit of normal. And then you want to also normalize your bilirubin. Okay, so you want your bilirubin to be less than 1. If you achieve this, this is the accepted criteria to say that you're responding to URSO. URSO has different mechanisms of actions and many positive effects in patients with PBC. The most important thing is that it delays histological progression. So, if you're starting with F1, F2 fibrosis, and then you respond to URSO, you should not progress to cirrhosis. And it delays the development of portal hypertension. And most importantly, it improves survival. So if you respond to URSO and you have early onset disease, your survival should be similar to the general population. And this is a nice slide showing you the effects of response to URSO on survival, what we call transplant-free survival. So you see in the blue line is patients that actually normalize their bilirubin, and here they use alkaline phosphatase less than twice the upper limit of normal, but I'm pushing for the 1.5, so let's say they normalize the bilirubin and the alk phos is less than 1.5, the upper limit of normal. These patients will have survival similar to the general population. In the red line, you see patients that had normal bilirubin, but the alkaline phosphatase did not respond the way you want it to the URSO. And you see a little bit of decline in terms of the transplant-free survival. And then in the orange line and the gray line, you see patients that had high bilirubin, alk phos is still high, and you can see that this has a significant impact on their survival. So again, if you diagnose someone early onset disease, you treat with URSO, they respond, you should reassure them, but if they don't, then they can progress and they can have a bad outcome. Now, this is new data that was published a couple of years now, but I think this is an important study, and I want you to focus on the figure on the right that says at 1 year follow-up. This was from a large cohort of patients with PBC, and they looked at the risk of them needing liver transplant or dying from their disease, and they looked at the threshold for the alkaline phosphatase, and you can see that if your alkaline phosphatase is less than 1, the upper limit of normal, you did okay. But anything above the upper limit of normal, you see that line starting to go up. okay? So now there is new data that maybe our cutoff shouldn't be just less than 180. Maybe we should try to push to even normalize the alkaline phosphatase, okay? This is, again, not endorsed by the guidelines, but this is new data and I wanted to share it with you. More recently at the last liver meeting also, there was data showing that probably the ideal response with bilirubin should be less than 0.5 milligrams per deciliter instead of less than 1, okay? So there is a push now among hepatologists that maybe we should, push, the labs, the alk phos and bilirubin to as close to normal as possible. So again, we start URSO on everyone with PBC, and then we need to decide, are we getting an adequate response to URSO or should we push for something else? So this is what you see in this figure. So the green dot, these are low-risk patients. So you diagnosed their PBC, they don't have advanced disease, you start them on URSO, and now your alk phos goes from 400 to 150, and the bilirubin is normal. These patients are okay, and you don't need to do anything else. Sometimes we diagnose PBC all the way to the right with the red dot. These are patients that show up with portal hypertension, end-stage liver disease, and maybe these patients, it's too late to actually do anything with pharmacologic treatment. You can start the URSO, but probably they need to be referred to a liver transplant program and get transplanted in a timely fashion. But what I want you to focus on is the patients in the middle. These are patients, you start them on the URSO, the alk phos, let's say, starts at 400. You treat them for 6 to 12 months, and now you're at 280. So you're still way above that 180 cutoff that we talked about. And these patients, you need to think about adding another agent to URSO, okay? And the only FDA-approved agent today is something we call obeticholic acid, which is a synthetic bile acid. This does not exist in nature. We make it in the lab. It's a modified quinodeoxycholic acid, and this is a second agent that you can add to URSO. So again, it's only indicated in patients that you start URSO, give them about 6 to 12 months. If they don't respond, the ideal response, then you can add another agent. And let me tell you a little bit about the mechanism of action of obeticholic acid. So in the liver, we have something called FXR, farnesoid X receptor. This is a nuclear receptor, and all these nuclear receptors, what they do, there's usually a substrate that they sense, and then when they sense the substrate, they upregulate or downregulate different genes that have something to do with that metabolic pathway, okay? And FXR is a nuclear receptor that senses bile acids, and in PBC, you have an issue with bile acid circulation, so you have increase in bile acids, and the main function of the FXR is to inhibit the enzyme that's the key limiting step in bile acid synthesis, okay? And this enzyme is called CYP7A1. So when you signal to FXR with bile acids, you decrease the synthesis of bile acids from cholesterol. And obeticholic acid is a very strong agonist of FXR. Ursodeoxycholic acid can also signal to FXR, but it's way less potent than obeticholic acid. So this is the main mechanism of action. We call it an FXR agonist. And this is the trial that led to FDA approval of obeticholic acid, or OCA, as a second-line treatment for PBC. It's called the POISE study, published in the New England Journal of Medicine. They randomized patients to placebo, obeticholic acid 10 milligrams daily, which is the highest dose we have. And then they did this titration arm where they started patients on obeticholic acid at 5 milligrams, low dose. And then they waited 6 months, assessed for response and tolerability, and then if they needed to increase the response and they tolerated the medicine well, they increased the dose to 10 milligrams daily. And then they followed these patients for 12 months total, and then they had an open label arm where they actually switched patients from placebo to obeticholic acid. Okay, and this is an important slide to understand the titration, because in real life, if you want to use obeticholic acid, you actually always have to start low dose, 5 milligrams, and the FDA label now says only 3 months, and then if they're doing okay, you can go up to the 10 milligrams. And I'll show you why we always start with the 5 milligrams in a second. So this is the primary endpoint, okay? And the endpoint was basically the percentage of patients that decreased the alkaline phosphatase to less than 180. and they had normal bilirubin, less than 1, and they had at least 15% reduction in the alkaline phosphatase from baseline. So it was really 3 outcomes in one, but this was the primary endpoint. And you can see in blue is the placebo response, it was only 10%, and red is the titration arm, so you start with 5 and then go up to 10, and then in orange or yellow, it was the high dose obeticholic acid, 10 milligrams from the beginning. And you can see that obviously patients in the obeticholic acid arms had better response than placebo, roughly speaking 45-50%. And it was not different if you started low dose and titrated up or if you started with the high dose from the beginning. This slide shows, again, the same thing. So red is the titration arm, yellow is the high dose, and blue is placebo. But here what you see is the first 12 months. This is the data I showed you. And then they did the open label, so they extended the study for an additional 12 months. And now the placebo patients in blue, they actually started on obeticholic acid. And you can see that the response is catching up to the patients that were started on obeticholic acid from the beginning. Now, this is why we always do titration, because I want you to just focus on the gray slice of this pie chart. And what you see is in the 10 milligram pie chart that 10% of the patients had to discontinue obeticholic acid because they developed actually worsening pruritus when we started them on obeticholic acid. This is if you start high dose from the beginning, 10 milligrams. If you actually start 5 milligrams and then titrate up to 10 milligrams, the discontinuation rate was only 1%. That's why we always start 5 milligrams daily and then we escalate to 10 milligrams. Another point I want to make is when you start obeticholic acid, typically it's add-on therapy to ursodeoxycholic acid. So you do not stop the urso and switch them to obeticholic acid. You actually add it to urso and continue the same dose of urso. But if you have a new diagnosis, PBC, and you start someone on urso and they tell you, I have side effects, I just cannot take it. These side effects could be diarrhea, change in bowel movements, sometimes skin rashes, thinning of their hair. If they tell you they cannot take the urso, then you can use obeticholic acid as monotherapy. And this happened in about 7% of patients in the phase 3 trial. So obeticholic acid is approved, again, mainly in combination with urso in patients with PBC that don't achieve the optimal outcome with urso, but could be used as monotherapy. So who's at risk for progression with PBC? Typically, we do assessment at baseline to determine the severity of the disease. I do a fiber scan, as I said, on every patient I see to see if they have cirrhosis, because many people will come to us and their liver disease advanced because they had fatigue for years, no one checked blood work, and they progressed to cirrhosis. You can do a biopsy if you want to or if you suspect that there is overlap. Typically, if we diagnose PBC in a very young patient, they have aggressive disease. I'll show you some data on this. Male patients, the ratio is 1 to 10, so 1 male for 10 females. But if you diagnose PBC in a male patient, and I've had a few, they have more aggressive disease. The presence of certain antibodies can be associated with more aggressive disease and having some of the variant syndromes that we discussed. Now, even if you diagnose early PBC, the 1-year mark after you start urso is very important because you want to see how they responded to urso. So people that normalize the alk phos and the bilirubin, they're going to do okay. And we have other things that we look at, and we have these mathematical models, something called the Globe PBC score or the UK PBC score. I'll show you an example of these, but if you're interested, they have actually phone apps for these. So if you just go to the App Store and type Globe PBC, it will show up and you can enter some variables. And it's nice because it will tell your patient what is the expected outcome over the next few years. This is an interesting study, and let's focus on just the figure on the left. They basically looked at liver stiffness as determined by FibroScan in patients with the newly diagnosed PBC. And they divided the patients into those with significantly elevated liver stiffness, which is more than 9.6 kilopascals, and patients that had lower liver stiffness, less than 9.6. And then they looked at survival according to baseline liver stiffness. And you can see that if you start with low liver stiffness, meaning no advanced liver fibrosis, you're going to do much better than someone starting with advanced fibrosis F3, F4. Now, the GLOBE score is, as I said, an online calculator that you can use, and it includes a lot of the variables that you need to determine at 1 year after you start treatment, including the bilirubin, alkaline phosphatase, but also the albumin and platelets, and these reflect the severity of liver disease. This is the actual website, and again, it's available as a phone app, and you see all the different variables you need to put in, and then once you click calculate, this is what you get. So you get a GLOBE score, and then it actually shows you the expected outcomes at 3 years, 5 years, and 10 years. And this is nice because, you know, this is a dynamic score, so you can add therapy, you can reassess in 6 to 12 months, and then recalculate the GLOBE score and show the patients that, okay, well, now we added obeticholic acid to ursodeoxycholic acid, the GLOBE score was this, and now a year later it's down to this. So it makes it easier to explain to the patients their prognosis. Now, PBC can be an aggressive disease. It can require liver transplant in certain patients, and unfortunately, it can come back after transplantation. So this is a longitudinal study. They followed patients for 10 years after transplant, and you can see at 5 years, roughly speaking, 25% of patients will have PBC recurrence, and it goes up as you follow them for longer. I'm going to skip through this. One thing that we started doing recently at our transplant program, and now we have data to support it, it seems like if you transplant someone for PBC and you put them on ursodeoxycholic acid even before they develop recurrence, that you can actually decrease the risk of recurrence. So now we routinely put all the patients with liver transplant for PBC once they're stable and they can take PO medications on ursodeoxycholic acid, and we use the same dose that we used for PBC before liver transplantation. We have a bunch of new medications that are being studied now to treat PBC and optimize the response, including some of what we call PPAR agonists. PPARs are also nuclear receptors, and typically they sense fatty acids and they regulate genes involved in lipogenesis. Actually, they also work on some of the genes that are involved in cholestasis. We have other FXR agonists that are being developed. We have something called FGF19, which is a hormone that is secreted from the gut, and then it goes back to the liver and it decreases bile acid synthesis. We have some proteins that are also involved in absorption of bile acids in the terminal ileum. And then finally, we have some immune modulators that are being tested. For the sake of time, I don't want to spend a lot of time on this, but one of these medications, which is a PPAR alpha agonist, is called bizafibrate, and these are the results from a recent clinical trial that assessed the efficacy of this drug to normalize alkaline phosphatase, and you can see that it was significantly better than placebo. Just to put it in perspective, I told you that let's take 100 patients with PBC. If you start urso monotherapy, probably you're going to be okay in 60 of them, but then you have 40 that don't have the adequate response. And these people, if you add obeticholic acid, I showed you that maybe 45 to 50% will be okay, so that would be another 20. So now, you know, you have 80 out of 100, they're doing okay. You still have 20 patients that may need something else. And we'll see if the future will have us do triple therapy. Maybe we'll do urso, obeticholic acid, and bizafibrate for the difficult to treat patient. There's some preliminary data on the FGF19, which is, again, a gut hormone that signals to bile acid synthesis. Looking promising, but this was a very small study. And finally, this is my summary slide. So when you diagnose someone with a new onset PBC, you need to do your baseline labs, imaging, make sure they don't have other autoimmune diseases. You need to assess for their symptoms, including pruritus, fatigue, dry eyes, dry mouth. You need to stage their disease. I do a fiber scan typically. I do a DEXA scan at baseline. And then you start your URSO, give it a 6 to 12 month period, reassess the treatment, and then you need to decide if you need to do a second line treatment. And finally, I'm just going to leave you with this slide. You see a few stars, and there's a black bear with a cholecystostomy tube and his gallbladder. If you can make the connection between these, I'll buy you coffee after the meeting. Thank you for your attention.
All right, there are some cards being passed out, so if you have questions, please either come to one of the microphones or hold up your hand or fill out one of the cards. I'm going to start us off a little bit by, asking Dr. Brown, management, I know you only had 2 topics that you were able to cover, but a lot of individuals struggle with kind of the less easy to address parts of cirrhosis management, like pain management, insomnia. So you talked about HE, but what do you tell your patients now when you've gotten rid of all their medicines that help them sleep, sometimes with confusion, and their uncontrolled pain? How do you manage that for them? Easy question to start with, right?
There's no easy answer. I'm not certain pain management is that easy in patients who don't have liver disease. I think the key, one thing that you can do is many of your patients have an inordinate fear of acetaminophen, and acetaminophen used at safe to therapeutic doses is the safest thing for them to take for pain. And so I tell them to use acetaminophen at 2 to 4 grams per day. You probably can get close to 4 grams per day. I tell them to take regular strength because 2 regular strength acetaminophen is 650. There's no data that it works any worse than 1,000. And for pain management, frequency of dosing does make a difference. So if they're taking 650 at a dose, they can take 4 doses a day and still be at under 3 grams per day. Whereas if they were taking 1,000 at a clip, they have higher. And as to insomnia, you should remember that insomnia or day-night reversal is often one of the early signs of HE, and so you should not treat it with sleeping pills. I tell my patients that if they have day-night reversal, we should treat them as encephalopathy. If they just have insomnia, I tell them to use melatonin. I don't know if it works, but I'm not going to prescribe sleeping pills to any person, ever.
All right, thank you. Eric, any additional tidbits?
Just in my patients with cholestatic liver disease, PBC, I use Benadryl once in a while at night because it helps with itching and then they go to sleep. So that's one thing. I agree, melatonin never works, but when it does, it's great. But I would say that's probably less than 10% of the patients. For pain, we use Tramadol. I don't know how you feel about Tramadol. I know it's yeah.
Yeah, it's probably better than narcotics, but only marginally so. I think we try to get our patients into pain management groups because, I guess, not that they're that great, but at least that's what they do. And I just can't be, I don't have the time or energy to do it well. And I think if you are going to manage pain, you have to manage it well. I use Doxepin, though, for itchiness at night. I think it's more sedating than Benadryl, and I think it might work.
What do you use,
little.
Bob?
Doxepin for my
I've
PBC or patients at night.
All right. Eric, I'm going to turn to you. Hepatitis B and C, what do you suggest for an easy algorithm for prevention of reactivation on chemotherapy?
Sure. So, of course, there's been a black box warning for hepatitis B reactivation now for a number of years in the setting of hepatitis CGA therapy. So it's easy if they have an indication for hepatitis B therapy, then obviously treat their hepatitis B before you treat their hepatitis C. If they don't have an indication for hepatitis B therapy, then you should watch. That's the only time when there is any indication to monitor labs. So if you look at the package insert of both approved therapies, there's not lab monitoring required. The one time there is when patients have hepatitis B, and then it's either watching the ALT. Some people watch hepatitis B DNA. Some people watch ALT. It doesn't matter what you watch as long as you watch something, and monitor for hepatitis B reactivation both on therapy and post-therapy. And I think I said something wrong because they shut the lights off on me. I don't know if this is like Walmart, it means it's time for us all to go home, or what that means, but hopefully I didn't offend anybody above here with the statement on hepatitis B reactivation.
I think the locusts coming in are more concerning. Maybe the dark will
Yes.
drive them away.
Yes.
Any other comments or?
So monitor not only on therapy, as my thought got distracted as the lights, I said something better, the lights are returning. So this is kind of like the hot-cold game. So as your comments get better, the lights get stronger. When your comments get worse, they get darker. So watch on therapy. And the other thing is off therapy. We should also be monitoring for hepatitis B reactivation, not only till the end of therapy, but in the post-treatment follow-up.
But was that question
Hep
about
C.
chemotherapy?
Chemotherapy.
So with chemotherapy, you should be far more liberal with Hep B prophylactic therapy. Anyone who's surface antigen positive, regardless of DNA, who's getting immunosuppressive chemotherapy should be prophylaxed. And then core antibody positive, we still prophylax anyone who's getting either a bone marrow transplant or an anti-CD20 containing treatment for hematologic malignancy.
Okay.
Cool.
I heard
That's okay. The
the question on
locus, the
hepatitis C
lights, we
therapy.
give
Yes.
you. And it's core irrespective of surface antibody status. I think that's also an important message.
Right.
That sometimes we get lulled into comfort because we think someone has a surface antibody. Their risk of reactivation is identical with or without the antibody if you have a positive core. What about Hep C and chemotherapy, though? I'll take my three experts. Do you do anything for Hep C? Do you withhold their chemotherapy and treat their Hep C first?
No, I mean, not unless they had hepatitis B lymphoma, where hepatitis C therapy may have some usefulness. That's the one time when probably hepatitis C therapy might be synergistic to their underlying disease. Otherwise, the cancer is going to kill them, not their hepatitis C, so we should certainly be aggressive and treat their cancer.
But we have had a couple very, very rare times when Hep C gets this cholestatic variant during immunosuppressive therapy. And you can treat Hep C during that period of time, and it seems like you have equal success, which was not true with interferon. So I agree with Eric, you treat the cancer, don't treat the Hep C at the same time, but if they get sick and have a flare, start Hep C therapy immediately. Don't wait it out or stop the chemotherapy.
So Naeem, I'm going to turn back to you. Part of PBC is family screening, and it's not unusual since our guidelines do suggest that screening with anti-mitochondrial antibody in first-degree female relatives is not a bad idea. What do you do for those AMA-positive individuals that have no evidence of cholestasis?
Yeah, I mean, as I said, about 1% of the population may have that positive AMA, and there's no evidence of any cholestatic liver disease. So I would just follow them with routine labs with their PCP, honestly, and say, hey, check your liver enzymes on a yearly basis. And then I just have a discussion with them about potential symptoms from fatigue to pruritus. I tell them about the association with other autoimmune diseases, but isolated elevation in AMA with completely normal alkaline phosphatase, gamma GT, I typically just counsel them, and I would like to hear from you guys what you do.
But do they all develop PBC? That's the first question.
Maybe I'm an isolated person. I don't screen family members of PBC for AMA.
No, they come to you.
I screen them with liver function tests.
Yeah.
So I didn't say that that was always the right answer, but some of the guidelines have suggested using AMA as a screening tool is not.
The worst place you can be is having someone with a positive AMA and normal liver function test, because it creates an enormous amount of stress with no direction to go. Because I get patients all the time screened by a dermatologist because they had an itch, screened by somebody because they were trying to get some other test. I have no idea. With stone cold normal liver function tests, in the beginning when I was young and bold, I biopsied a few of them. They were all normal. I stopped doing that. And now I tell them that I don't know what's going to happen. But to date, not a single one of them now with up to 10 years of follow-up in my practice have gone on to develop abnormal liver function tests. Now, maybe when I'm long retired, they will, but that's a lot of time to be fretting about something that they don't have. So I would caution against, I would recommend against screening family members who have normal liver function tests or anyone with normal liver function tests for AMA, because then you'll be remembering this moment and saying, you're right, he was right for a change.
Naeem or Eric, Bob didn't leave you much room to argue, but you certainly still
Bob,
can.
feel free. I'm happy to be disagreed with.
No, this is a true story. It happened to me. I had this patient with positive AMA, but completely normal alkaline phosphatase, and she was having an endoscopic ultrasound to look at her pancreas for a separate issue, and we're like, okay, let's just do a liver biopsy, because now you can do the biopsy that way as well. We did a liver biopsy, and it showed nothing. So I'm like, okay, you know, we should be reassuring. But she is convinced that she has PBC, and she's on IVIG and tons of supplements, and just a few days ago, she called me, and her ALK phos is like 121 now, and she wants to get on treatment for PBC, and so it can create a lot of issues. I agree, but what happens sometimes that you have a family member with PBC, and then the patients will go to their PCP and they do the AMA and they come to you, and then you have to explain to them that they're at risk, but they don't have the disease yet. We need long-term follow-up. So the honest answer is we really don't know what to do, but I mean, I reassure them and say we'll follow you over time.
Yeah, I mean, I think reassurance and education is probably the biggest part of that clinic visit, and if you can really diffuse I make the analogy, a lot of people know about ANA and that people have positive ANAs forever without any clinical consequence, so a lot of times I'll make that analogy because people sometimes heard about a positive ANA and that just because you have an antibody doesn't mean you have a disease, and I think the key to that clinic visit is education and reassurance, and if you're able to kind of overcome that, a lot of the patients, I have a handful of these patients too that I've seen with a positive ANA, and once you kind of talk them down from the cliff and tell them they really don't have a disease with a normal ALK phos, they are reassured, and then obviously we teach them that alkaline phosphatase when they're at their primary care doctor. You can watch that. If it's not moving, they still don't have a disease, and if they want to monitor something themselves, that's something that they can ask their doctor what their alkaline phosphatase is, and if it ever goes up, there's a great reason to come see me rather than at the grocery store, and then we can actually maybe talk about something.
And since we're speaking about autoantibodies, I just want to tell you guys that about 15% of patients with NASH will have a slightly positive smooth muscle antibody. Okay, so don't overreact to these. If the titer is 1 to 40 and your total protein is fine and you don't have any signs that there is increase in immunoglobulin, especially if it's a male patient with no other autoimmune diseases, don't overreact. It's not autoimmune hepatitis. If your SMA is 1 to 320 and your total protein is 9.5 and your albumin is 3.5, you see a gap, or they have other autoimmune diseases, you can have overlap autoimmune hepatitis and NASH, but autoantibodies can be tricky, so just know that 15% of patients with NASH will have low titers for SMA or possibly ANA.
And not only with NASH, but hepatitis C also has a lot of positive autoantibodies with a polyclonal gammopathy. So again, you're going to see them, and I get consults, oh, this patient has hepatitis C and autoimmune liver disease. Oh, an overlap. No, they just have some antibodies in the setting of their hepatitis C, cure their hepatitis C and all as well. So.
And that's why in my practice I've evolved to, I look for the common liver diseases first and don't send autoantibodies until I've ruled out the common liver diseases. So, some people like to send everything on the first day. The lab loves them because they get a huge bill, but you end up with a lot of false positive tests. So I look for alcohol, non-alcoholic fatty liver disease, hepatitis B, hepatitis C, iron studies, and celiac. And then only when all those are negative do I look for the ANA, the AMA, alpha-1 antitrypsin, et cetera. Because most of those patients who have negative for what I call the big five, they're going to end up with a liver biopsy anyway. And so, because you're not going to treat them empirically for autoimmune hepatitis. Only the PBC can be diagnosed definitively without a biopsy. And then the rest of them are going to end up with a biopsy. And so you can defer a lot of this worry and stress by not sending the tests up front.
There is a question?
Yes, I'd like to pick your brain a little bit. In the setting of established portal vein thrombosis and severe thrombocytopenia due to cirrhosis, what would you prefer, platelet transfusion versus the new sort of platelet boosting agents? that patient needs an intervention and it has platelet count of around 20, for example?
Oh dear. If you want to know what I really think is better, if you really think you need the platelets, a TPO agonist is always going to be better at getting the platelets up than a platelet transfusion. Though I didn't show you the data, when you look at the placebo arm, the efficacy of the platelet transfusion at lifting the platelets is pretty minimal. So, and then you have to balance that with this, potential risk. Now, if you look back to what led to this boxed warning in CLD patients, it was the ELEVATE trials of L-thrombopag, where the dosing was probably too high, the platelet counts went high into the 200s, and PVT was reported, and there was no placebo arm. And so I think the answer is that you don't have a good answer, but if you really were going to do something if you really were at risk, that a TPO agonist would be used. Now, the boxed warning is for thrombotic events. There is no contraindication, but patients with PVT were not included, and actually in some of the trials, you had to have a portal vein flow that was sufficient to even get in. So I would say proceed with caution.
Correct. So I had the exact same thought process, but unfortunately, the hematologist was in the other side of the spectrum and said, no way, no medication, platelet transfusion. And I already had this problem because the platelets won't last any longer than a day or two, and you get delayed problems.
Okay. So luckily we've taped this, so you can take that clip of Bob and take it to the hematologist.
Mm-hmm.
There are other questions. I do want to release everybody for a break, so I'm sure that all of us will answer your questions while the rest of you get coffee and cookies and come back for an anticipated 3:15 start for abdominal pain. Not from coffee and cookies, hopefully.
Well, welcome back, ladies and gentlemen. I'm Larry Schiller, a gastroenterologist from Dallas, and it's my pleasure to moderate the next portion of the program today. This one is about luminal GI problems. So we'll be discussing somewhat different things than you've done in the first session already. And we have a wonderful program, I think, planned for you for this session. And then we'll review the questions that you took a stab at earlier, see how you've done, and have a question session after the formal talks. And I want to remind you that there's a reception that will be in the lobby out front following the conclusion of the symposium. So stay around for that. You don't want to get into the traffic too quickly. All right, well, the first the topic of discussion for today is my talk on chronic abdominal pain, making a diagnosis, and what to do when you can't. And this is a problem I'm sure you see in the office every day. And for some of the things that cause abdominal pain, we're quite good because we've been trained to appreciate physical causes of pain like cancers and inflammatory bowel disease, and we almost never miss those things anymore. But for some of the functional problems that cause pain, there's a lot of grief that both the patients and physicians experience as we try and make sense of what the problem is and how to best deal with it. I have several disclosures to disclose to you, and here they are. I try to be equally unbiased for each of the products. Well, let's start off with talking about pain. Well, pain is a big problem. You hear about this almost every day as far as what physicians should do about it and what we shouldn't do. Physicians have been encouraged to treat pain more aggressively over the last 20 years. And as a result of that, controlled substance prescriptions have skyrocketed. And this has led, as one might have predicted, to more episodes of oversedation, more abuse, and more diversion of opiates to people who are taking them for recreational purposes. The thing that I want to stress to you in today's discussion is that new classes of non-narcotic pain medicines are available and might be used in GI patients. They are being used by our colleagues in other fields. They haven't been studied all that well in GI problems, but perhaps it's time that they ought to be.
Well, pain is a symptom that may reflect tissue damage or injury. That's its useful purpose. That's nociceptive pain. But it can occur in the absence of tissue damage or injury, and that can be neuropathic pain where the pain system is misbehaving, or psychogenic pain where the brain is causing the problem. Pain can be acute or chronic, and it has an extensive and complex differential diagnosis. Abdominal pain in particular may arise from any intra-abdominal organ or structure, the abdominal wall, which is generally an underappreciated cause of pain, and extra-abdominal organs where it causes referred pain. Now, determining the cause is pretty straightforward. We need to think about the big differential diagnosis of pain, and to work our way through that, history is really the key. The time course, whether it's acute or chronic, the variation of pain with time, the location of pain, the quality of the pain, initiating factors, relieving factors, and the relationship to things that change the function of the GI tract, like eating, having bowel movements, the position and movement of the patient. On physical findings, tenderness is a key issue, whether it's diffuse or focal. The relationship of tenderness to contraction of the abdominal wall is an important feature to look for. Whether there's coexisting distension, what the state of the bowel sounds are, and whether there's any organomegaly. And then associated symptoms that go along with the many diseases that cause pain. As I said at the beginning, we're all good at sorting through this level of behavior because we're looking for causes of pain that could be classified as physical or organic. And again, we're very good at that. Some of the structural visceral causes of abdominal pain include inflammatory conditions of the upper abdomen. Again, we don't miss many patients with ulcer disease who have abdominal pain because almost all those people get scoped at some point. Same thing with many of the other issues. With good advanced imaging now, we can see people who have gallstones. In the past, when I was a fellow, it was an iffy diagnosis, and then ultrasound came along and it was pretty clear who had stones and who didn't. Cancers of the upper abdomen, same thing. Hepatomas, which you heard about in the last session, cholangiocarcinomas, pancreatic cancer, gastric cancer, lymphoma. Very few of those go undiagnosed for very long. There's still some that are missed on imaging and that show up several months later, but eventually that's all figured out and we make the diagnosis and treat it more or less successfully. Inflammatory conditions in the mid and lower abdomen like enteritis, colitis, diverticulitis, again, were helped greatly by modern imaging, which rarely is misleading in that. Bowel obstructions, from whatever cause, again, we pick that up easily with imaging. One structural problem we do have difficulty with still are vascular problems, and that's because they happen infrequently enough that they're not high up on our differential diagnosis. And unless you're concerned about this, you may not do the right test to sort out mesenteric vascular insufficiency or abdominal aortic aneurysm. We also have difficulty with referred pain. So referred pain from the chest sometimes goes undiagnosed for a while. Urinary tract problems, again, may not show up on imaging as well as they ought. And then pelvic problems in women are something we need to pay more attention to because they often will cause pain that may be indistinguishable from pain due to abdominal organs that we're more comfortable with dealing with in the GI tract. Now, the big issue that gastroenterologists have, as well as internists and others who see patients early on in the course of things, are the functional abdominal pain problems. Because these things don't show up on imaging, they don't show up on endoscopy or colonoscopy. And we make these diagnoses because of the constellation of symptoms that the person has, and often the fact that we don't come up with other things on the diagnosis. So to some extent, doctors remain a little bit unsure of the diagnosis when these things come up, but they're certainly very common. And if you look at the bookings for a typical general gastroenterologist, about half the patients that they encounter have one or more functional problems that are causing their consultation. So we need to think about these things. Now, the way that's been developed is to use criteria, and these have been developed along the way, but it's important to recognize that the criteria were set up so that researchers could do research in a more uniform fashion. 40 years ago, if you were doing a study on IBS, your definition of IBS had as much credence as the next person's. And often they were very different. And so in an effort to standardize that, about 25 years ago, researchers got together and came up with the initial Rome criteria to try and sort out functional problems from other things. But the thing you have to realize is these are arbitrary criteria. They're tested in the sense that they're reproducible and they generally pick out a reproducible group of patients, but they're arbitrary. And there are lots of patients we see that come in with complaints that don't meet the criteria. And these non-conforming patients are ones that are particularly troublesome because it's all well and good to say, well, with IBS, you only need to do a minimal evaluation and then launch into treatment. That makes great sense. But if you have someone who doesn't exactly conform to the criteria, then you're sort of in a bit of a muddle doing that. It's possible that they have something else. In general, when it's been studied, and it's been studied very infrequently, non-conforming patients turn out to have a milder form of the functional problem that they're thought of having in the first place. So I'm not sure we need to be super rigid about the criteria, but if the criteria aren't met, you should be a little skeptical about the diagnosis and think about other problems that the person may have. Now, one area which we all basically could improve on are less common causes of abdominal pain. And that includes abdominal wall pain, such as we see when people have had laparoscopic surgery and have a port site. They may have a very distinct pain due to scarring and nerve entrapment at the site of the port scar. You can have nerve entrapment syndromes that happen as the nerves traverse the abdominal wall. And these produce very reproducible syndromes and can be diagnosed fairly readily, which we'll talk about in a minute. Abdominal wall hernias, sometimes they're not as fastidious as we ought to be in the examination, and these can cause pain that again is typically localized. And then there are a whole bunch of patients who have fibromyalgia, which is the rheumatologist's version of irritable bowel syndrome. These people have soft tissue pains all over their body, and that can include the abdomen. And so if someone is pointing out a number of distinct painful points on their abdominal wall, and those areas are a little tender, they might have fibromyalgia. Also, radicular nerve pain, such as can be seen with shingles or post-herpetic neuropathy. Thoracic spine problems, you can have a thoracic disc that's dislodged and pressing on a nerve and producing abdominal pain. And then neuropathy, which has become a very popular diagnosis in the general clinic population and can affect the nerves that innervate the abdominal wall. Then there's some rare syndromes, angioedema, porphyria, and lead poisoning, that we need to keep in mind, but they're the unusual syndromes. So let's first talk about abdominal wall pain. This is the most common overlooked cause of chronic abdominal pain. It characteristically is localized tenderness. So if you palpate the abdomen carefully, you can find a spot that reproduces the pain with pressure. There's typically no relation to meals or bowel movements because the abdominal wall doesn't move that much with those things. It may be related to position or movement of the abdominal wall, and you'll note increased pain with tensing of the abdominal wall, so-called Carnet's sign. And that's an important physical finding if you detect it. So as you're pressing around on the abdominal wall, if you detect a spot that's sore, ask the person to raise their head up a bit or to tense their abdominal wall in some other way, and that will tend to increase the pain. And there are characteristic locations where abdominal wall pains occur. One of these is along the edge of the rectus sheath, where the penetrating nerves come out, and also the nerves that come around from the intercostal nerves will go out and penetrate through the abdominal wall. You can have the ilioinguinal nerve down here, and the iliohypogastric nerve. Those typically can become entrapped in the muscle layers, and then any laparoscopic port site. So again, if it's localized pain that they're complaining of, this can be the source of it. And it's an important diagnosis to make because this gets treated completely differently than any other sort of pain that we have. Dr. Van Assen in the Netherlands came up with this little schema, and you can download it from that reference that's at the bottom of the page, of 18 questions you can ask the patient Most of these are questions that pertain to irritable bowel syndrome and would be positive or a yes answer with that. And they don't have that same relation when it's abdominal wall pain. There are some that deal with the localization of the pain, but it's a very easy checklist to go through. And it works out pretty well. If you use a 10-point cutoff for it, it has 94% sensitivity and 92% specificity for making a diagnosis of anterior cutaneous nerve entrapment syndrome. So that's something that is worth considering when your patients have gone for a while. And the typical patient that I've seen with this is someone who's seen a couple gastroenterologists already, been scoped numerous times, has negative findings, but has very localized pain. And the neat thing about it is that you can do a localized nerve block and get rid of the pain instantly. So if you have some lidocaine around the office or bupivacaine, you can inject some of that into the abdominal wall where it hurts. Give it about 5 minutes to diffuse around to the nerves, and the pain will go away. And the patients recognize this. They'll tell you, oh, that pain I've had for the last 5 years is gone now. And that's very rewarding for them and for you, because it really establishes the diagnosis. So again, you can confirm the diagnosis by injecting the trigger point with a local anesthetic. It's not a big deal thing to do. I feel comfortable doing it. You can repeat the injection, maybe with a corticosteroid when the pain comes back. It typically will come back as the local block wears off, but sometimes it doesn't. If you have to do that more than a couple of times, you probably want to refer them to pain management. They can do a more formal nerve block or a neurolysis kind of procedure. And pain modification therapy that we'll talk about later with things like tricyclics and gabapentin can be helpful in this group of patients. Radicular nerve pain is somewhat similar. The somatic nerves, the intercostal nerves that come down onto the abdominal wall from the chest wall, mediate sensation on the abdominal wall. They can be affected by trauma, thoracic spine problems like disc disease or arthritis, post-herpetic or diabetic neuropathies. The pain here is characteristically unilateral. The pain doesn't cross the midline because you're dealing with a somatic nerve, not a visceral nerve that's detecting things from the inside. And it'll be delineated and may well have a dermatomal distribution. There's no relation to meals or bowel movements again. It's a constant pain. It may be positional. And intercostal nerve blocks are diagnostic or therapeutic. That's something I would recommend you send to somebody who's trained to do rather than attempt that in the office. Angioedema is another uncommon cause for abdominal pain. And you may have recurrent bouts of pain with hereditary angioedema. The diagnosis typically is delayed. It can be 8 years or so. And typically the pain is episodic. It's not there every day like some of the neuropathic pains are. Type 1 angioedema has reduced serum concentration of normal C1 esterase inhibitor. That's about 85% of cases. And that's what you can measure with any of the tests for C1 esterase in the blood. The type 2 has a mutated dysfunctional C1 esterase inhibitor, and in that case, you need to do the functional assay for C1 esterase. Type 3 is the hardest for us to diagnose. They have normal levels and function of C1 esterase, and they have other problems. So coagulation factor 12 and bradykinin can be mutated and cause this syndrome. Typically, these people will have hives elsewhere than in their gut. And so they may also complain of having swelling of their arm or their leg or their face or whatever as episodically as they have abdominal pain, but that's not always the case. Porphyria is another thing that's a rare cause for this problem. Only acute porphyrias produce neurologic problems and abdominal pain though, so remember that. Acute intermittent porphyria, hereditary coproporphyria, variegate porphyria, and ALA dehydrate deficiency are all things that can cause acute porphyria and abdominal pain. Not porphyria cutanea tarda, the kind that we see with liver disease, or erythropoietic protoporphyria. And the thing that's key here is to measure the urine porphobilinogen during the attack, because it will be low under those circumstances, or high. Okay, well, what do you do if you've gone through your differential diagnosis and you can't make a diagnosis very well? You're still left with a patient with pain. Well, that's a time when we think about using pain medicines. And We have to think about the neurophysiology of pain. It's a sensory experience that's created by the central nervous system. And so pain does not exist outside of your brain. It reflects inflammation and tissue injury and may result from dysfunction in the pain recognition system, which are the peripheral nerves, the spinal cord, and the brain. It involves several layers of processing, and there are numerous potential targets for analgesics. Now, pain sensation involves the peripheral sensory nerves, the nociceptors that are on the ends of those nerves. There, the acute output tends to be proportional to the stimulus. So the more inflammation, the more trauma you have, the greater the output of those nerves. But these nerves can become sensitized, particularly if you have a chronic painful situation. If they keep doing the same thing, they get very good at it. It's like anything else with our nervous system. And so lesser degrees of stimulus may cause a large degree of pain with time. In the spinal cord, we have spinal interneurons that relay the message to the central nervous system. And again, sensitization can occur there. There are also descending pathways from the brain that go to the spinal cord and modulate those spinal interneurons. So they will reduce pain. You have centers in your brain that will turn off the pain signaling and make it more appropriate. And we take advantage of those descending pathways with some of the pain-modifying drugs that we use. And then in the brain, you have, in addition to saying, well, there's a pain in my finger, it gives you some emotional context to the pain. Oh, that's the pain I had when I hit my finger with a hammer 10 years ago. You remember things like that, and you add emotional context. I'm really dumb to hit my finger with a hammer. Now, neuromediators in the dorsal horn are key to many of the targets for pain medicine. So they're excitatory neuromediators, and you can use things that reduce their activity. And they're inhibitory neuromediators, things like the opioids that turn off the pain signal. And you can use things that tend to stimulate those pathways. So receptors for these trigger and inhibit output via the spinothalamic tract up to the brain where the signal gets interpreted. So this is an important switching point for pain messages. And if we can modify the amount of pain signaling going up to the brain, we'll reduce the amount of pain that we're sensing. In the brain, the thalamus receives signals from the spinothalamic tract. The thalamic pathways that come out from there are distributed widely. They go to the primary sensory cortex to tell you where the pain is coming from, the limbic system and frontal lobes that give the affective response, and the hippocampus, which signals that memory of pain. Now, descending inhibition, I mentioned earlier, are pathways from the brain to various levels of the spinal cord, and they release opioids, noradrenaline, serotonin onto the dorsal horn neurons and modulate their activity to tend to decrease that. They inhibit the output of the dorsal horn neurons and therefore reduce pain signaling to the brain. So things that mimic the effects of those endogenous opioids, the exogenous opioids that you may use, or things that increase noradrenaline or serotonin levels in the spinal cord can reduce the amount of pain signaling to the brain. Now, chronic pain is another big problem. And again, sensitization is important. You can have peripheral sensitization at the level of the nociceptors and central sensitization. All of this tends to make pain signaling more efficient, and so you feel more pain. Now, if we think about the drugs that we can use for this, opiates work primarily at the spinal level to inhibit the dorsal horn neurons. They effectively treat most forms of pain, and they've been the standard for potent analgesia. There's a lot of bad press that the opioids have had lately for good reason. When they get used widely, about 10% of the population is susceptible to getting addicted or using them more than they ought to. And that group suffers a lot of complications as a result of that and has caused a lot of grief. Now, the response to that has been to try and cut down on the availability of these drugs for everybody, even the 90% who might not have that problem, because we don't have a good test to sort out the people who are going to get into trouble ahead of time. So the advice is to use these as little as possible. And in point of fact, very few gastroenterologists use opioids chronically for pain. I think that's something we sublet to the pain doctors if we're at that point in dealing with a patient. But the thing to keep in mind is they're non-opioid pain medicines. They can affect the effectiveness of opiates. They work at peripheral and central levels, and they may reduce sensitization. But none of these drugs are approved by the FDA for this use. And so you need to discuss them with the patient and point that out to them. Well, what are these drugs? Well, we have non-steroidal anti-inflammatory drugs, usually one of the least favorite groups amongst gastroenterologists because they cause a number of ulcers that we have to deal with, but they're good pain medicines. There are anticonvulsant drugs that can be used to mitigate pain, neuromuscular agents that seem to help, alpha-adrenergic drugs, and antidepressant drugs. We'll talk about these all briefly. So non-steroidals work on the prostaglandin system, and prostaglandins sensitize nociceptors to other mediators. So if you reduce prostaglandin synthesis, you reduce the sensitivity of the primary afferent neuron, and they're useful in people with abdominal wall pain or with cancer pain. Ketorolac, which is an injectable non-steroidal, has an efficacy that's close to morphine when it's been studied. So you may think of Advil and those kind of medicines that you can get over the counter in the drugstore as not being very powerful, but in fact they can be. You just have to use them properly. Now the problem is side effects. Dyspepsia and ulcer disease happen. GI bleeds happen, as we well know. These also can cause diarrhea and renal dysfunction in patients, abnormal liver tests and jaundice, and impaired cartilage repair. So they're not without downsides. And there are also drug interactions you need to school yourself about. So look over the drug list when you go to use these medicines. Anticonvulsant drugs were developed to reduce repetitive nerve discharges in the brain associated with seizures. But they're useful in neuropathic pain, and they've been tried in other painful conditions, such as central pain, porphyria, migraine, phantom limb neuropathy, postsympathectomy pain, Fabry disease, multiple sclerosis, and diabetes and peripheral neuropathy. So those problems do seem to get better with these drugs. This shows you a list of some of these drugs. The ones with asterisks have some FDA approval for painful conditions. Again, none for GI pain, but things like neuralgia, migraine, or fibromyalgia. And in point of fact, we don't use too many of these in GI other than pregabalin and gabapentin, which seem to be of some use. Now, I say seem advisedly because, again, they have not been tested in vigorous large studies in patients with GI pain. Carbamazepine is a drug that's related to the tricyclics. It inhibits norepinephrine uptake, blocks sodium channels, so it increases norepinephrine levels in the spinal cord. It's taken with food to avoid gastric distress. There are a number of adverse events, including abnormal liver tests, and you have to monitor this closely. This does not get used widely by anybody, including gastroenterologists. Gabapentin, though, is used fairly widely. It resembles the structure of the neurotransmitter GABA, but interestingly doesn't interact with the GABA receptor, and its precise mechanism of action is uncertain. The dose can be titrated up to 1,200 milligrams 3 times a day, but it should be titrated up. You shouldn't start with a big dose because you can get sleepiness with this drug. And if someone has renal insufficiency, you can't use a full dose of it. There are a number of other symptoms that come up, and you have to monitor people. If you start someone on these medicines, you're responsible for monitoring them. Pregabalin is a GABA analog, and it interacts with that receptor. It binds to a voltage-gated calcium channel, is effective in a fairly broad range of doses, but again can cause dizziness, somnolence, or headache. And it's regulated as a controlled substance because of the potential for CNS depression. So it's a Schedule V drug, but the FDA has been alarmed by this drug in various ways, and so you see it gathered up in the opioid epidemic discussion. Neuromuscular drugs, baclofin's a GABA B receptor agonist, and it's used in pain pumps that you see some patients with chronic pain get. Adverse events are common, though. I don't recommend you use it regularly in GI patients. Cyclobenzaprine is related to the tricyclic drugs. Methocarbamol, metaxalone, or skeletal muscle relaxants. It sometimes can be adjunctive with other sorts of muscular pain in the abdominal wall and pelvic floor. Alpha-adrenergic agonists include clonidine and tizanidine. Clonidine can mitigate opiate withdrawal syndrome. We use it sometimes when we have patients who we're trying to withdraw from opiates because of opiate bowel syndrome. For the analgesic effects, the patch delivery system seems to be best since it gives you a constant low level, but the antihypertensive effect may be limiting, although interestingly, not so much in people with neuropathy, because this drug works as an antihypertensive by its action on central adrenergic sites, and so if you have neuropathy, that system doesn't work too well. Tricyclics are used frequently by gastroenterologists. These inhibit serotonin and norepinephrine reuptake, so it increases the level in the spinal cord. It increases the effectiveness of the descending inhibitory pathway, and they're best thought of as pain modifiers. You're not going to give someone a dose of amitriptyline and the pain goes away in the next 10 minutes. Instead, what happens is over the course of several weeks, the pain level will decrease gradually. It's effective in low doses when it's used for this purpose, and that's important to note because in antidepressant doses, which are 100 or 200 milligrams a night, it has a lot of side effects and interacts with a lot of drugs and produces a lot of problems and is on the bad list for use in seniors. But these low doses are very good in terms of pain modification without having anywhere near the number of problems that an antidepressant dose will have. Again, you need to tell a patient up front it may take weeks for it to work, so they shouldn't judge its effect too promptly. Side effects are mainly due to the anticholinergic effects of some of these, particularly amitriptyline. You can get constipation, dry mouth, or tachycardia. People also complain of weight gain and sedation at times. And again, use it with caution in the elderly, mainly because of falls. If someone has narrow angle glaucoma that's untreated, that needs to be a contraindication if they have heart block or have just had a heart attack. The more advanced antidepressant drugs, or I guess the more recently discovered ones, the selective serotonin reuptake inhibitors, have less evidence of effectiveness for pain than the tricyclics do. The antidepressant effect is substantial. A lot of patients with chronic pain are depressed, so it's not a bad choice for that aspect of their illness. But there are lots of side effects that can occur with these patients, and you need to keep aware of those. Serotonin or epinephrine reuptake inhibitors are probably more effective at dealing with chronic pain. Duloxetine has been approved for diabetic neuropathy, fibromyalgia, and chronic musculoskeletal pain, again, not for GI problems. The adverse effects are similar to the SSRIs, but there may be less sexual problems. So in using these, there's limited evidence in a limited number of conditions. The generalizability of the evidence is uncertain. There are small studies, variable design, mixed results. They should be used with caution, pay attention to side effects. Seek pain management consultation if you're insecure about using these agents. I think that's an appropriate thing for gastroenterologists to keep in mind. We also have to think about behavioral interventions for chronic abdominal pain, things like cognitive behavioral therapy, dynamic psychotherapy, hypnosis, relaxation therapy, guided meditation, positive ideation, all have advocates. And there's several meta-analyses that suggest effectiveness at least as good as pharmacologic therapy for things like pain in IBS syndrome. So to sum up, abdominal pain is a common problem that often is due to visceral causes. We're good at picking those up. When no anatomic problem is documented, functional syndromes may be diagnosed. Be sure that the criteria are met before you start treating the person according to what those criteria-based interventions suggest. Abdominal wall pain is the most commonly overlooked cause of chronic abdominal pain, and other misdiagnosed problems include radicular nerve pain, angioedema, and acute porphyria. There are good reasons to think that non-opioid pain medicines could work in many painful gastrointestinal conditions. Evidence is lacking for benefit for most of these drugs for most GI conditions, but that's because they haven't been studied. Off-label use may be reasonable if the alternative is long-term opiate therapy, and consider behavioral interventions for refractory cases. So thank you for your attention, and please jot down any questions. We'll have some time for questions at the end of the lectures. Well, it's now my pleasure to introduce the next speaker, who I say very confidently has come further to give this talk than any of you have come to listen to it. And this is Dr. Peter Gibson, who is the head of luminal gastroenterology research in the Department of Gastroenterology at Monash University in Australia. So that's on the other side of the world, and we appreciate Peter making the effort to come be with us today. You're all familiar with his work if you've heard about the FODMAPs diet. And Peter, I think, can claim paternity as the father of the FODMAPs diet. So it's with great delight that I welcome you to the podium.
Well, Larry, thanks very much for inviting me to talk, and it's always a great pleasure to talk about the new way for managing irritable bowel syndrome, because it is changing and it's become a lot more pleasant to manage and a lot more successful, I believe. And hopefully I'm going to convince you of that. Now, I haven't, my conflict slide didn't, declaration slide didn't make it up there, but it's on your tablets. But one thing I will say is that the only potential conflict, which is probably a positive one, is that I do work for Monash University and they do financially gain from sales of apps and teaching courses and things associated with the FODMAP diet, but 100% of the money they get for that goes back into the FODMAP program, which is the reason why we've been able to do any research at all in this area. So just please note that. Now, management strategies have completely changed, I believe, in IBS in recent years. Making a confident diagnosis, of course, is a key part, and Larry's talked about several aspects of that. And then harnessing the placebo, that's the most powerful tool we have in any chronic condition, is really important, and there's evidence base to say that it's good. However, many patients require specific therapies, and I think there are 3 specific groups of therapies that we should utilise. There's dietary therapies, psychological therapies, and what I'd like to lump together is adjunct therapies. And the adjunct therapies include drugs, manipulating the microbiota, and things like physiotherapy, pelvic floor, biofeedback, which I don't have time to talk about today, but is a very important non-pharmacological technique. So why do I put dietary and psychological therapies as key key members of this strategy? Well, they're well-defined strategies. They're not just woolly, non-specific things. They're very well-defined. If you have a chronic condition that's non-life-threatening, curative, and there are no curative drugs, taking a drug that works only for as long as you take it is not a very attractive option. And if you can manage lifestyle and psychological issues for this condition, it's a lot more attractive. Both of these types of therapies do have efficacy for all symptoms in 3 out of 4 patients, irrespective of what sort of Rome classification they have according to their bowel habits. These things are self-empowering, so that the patient can rely upon themselves rather than relying upon the doctor to help them. But if we're going to do them, they're not simple things. We have to apply them with intelligence and knowledge of what they are, and have to be aware of the risks and who should or should not be treated with them. So what about diet? Why diet? Well, our patients have been telling us for a long time, and there are lots of studies which have shown that ingestion of food triggers symptoms in at least 60% and probably more like 80% of patients. There's a huge community and patient interest in using diet to treat illness. You only have to read newspapers, magazines, and look at the internet to be aware of that. Diet is a thing that patients have used for a long time, and there is even some studies which have documented this, that it's the primary behavioural therapy, the factor that is manipulated by those patients. Now, the other thing that I think is much understudied, there are multiple mechanisms by which food can cause symptoms, can induce symptoms. And only some of these have been studied, and I think there's going to be a lot more work in the future which is going to widen this area. We now have a randomised controlled trial evidence that of dietary change is efficacious, and if we don't engage as medical practitioners and nurse practitioners, then the naturopath will or Dr. Google will, or the lady next door who will tell you all about how to fix your conditions. Now, the most common dietary strategies that were recently, the American College of Gastroenterology did a detailed review, and that the most common strategies that they considered in the USA are gluten-free diet, low FODMAP diet, and exclusion diets based upon some immunological criterion like antibodies to food or leukocyte activation tests. And their recommendations were that we suggest a low FODMAP diet for overall symptom improvement in IBS, but gluten-free and exclusion diets were out because of just a sheer lack of evidence. In fact, gluten-free diet has got one randomised controlled trial which showed that you improved your numbers of bowel actions in people with IBSD by less than 1 a day. And I'm not sure what less than 1 a bowel action is. 0.75 of a bowel action is always quite amusing to me. Just consider what that is, what that really means. Now, you will note that the recommendations here are weak and quality of evidence very low, but you'll always find that for dietary studies because these are done with the grade criteria which are designed for drug. And drug studies are much easier than dietary studies. You can't do huge studies. There's always problems with designing placebos, and so this is why it gets that classification. Now, the FODMAP concept is nothing, it's been around for a long time, but not utilised in such a way. We've known for a long time that fructose, lactose if you're hypolactasic, fructans, which are fructooligosaccharides, galactooligosaccharides, which is the things that are in legumes, baked beans, etc., and polyols like sorbitol and mannitol. Each of these, if you give them to people in drinks, will induce symptoms. And they all do similar things. They distend the intestine, stretch the wall, they are fermentable, and so you get more gas, you distend the wall, and mechanoreceptor stimulation is one of the major ways that we get that is the sensory input which causes bloating, pain, and secondary changes to the bowel. Now, we know that these things do this because you can see it visually, as in here with this work from Nottingham with Robin Spiller's group, where this is the same, the white is a small bowel water, and this is after glucose and an equivalent dose of fructose. You can see the difference in the amount of water present there. And when we first were looking at this, we designed a high and low FODMAP diet and put it into healthy people and people with IBS. Got the same answers, that the amount of hydrogen coming up in the breath, which is a measure of fermentation in the bowel, was when it was a low FODMAP diet, was very minimal. Whereas if you put people on a high FODMAP diet where they just had 3 meals a day, there was high FODMAP, the hydrogen was elevated all day. There was fermentation going on all day. It wasn't just a little blip after each meal. So the whole theory with the low FODMAP, with the FODMAP concept, was that if we add these together, we will get a much more bang for our buck. That we will help their symptoms more, because if you just restrict fructose or just restrict lactose, these things don't work very well. They've had no penetration in our therapeutic armamentarium. Now, FODMAP was a term that was, we created this as an acronym, which actually is a meaningful acronym, but it was so that we could get people to think about them as a collective issue. Rather than getting obsessed, there's been a huge obsession, particularly in Australia when we're doing this, about fructose. There's been an obsession about lactose, but we want people to think about them as a collective thing. And so that's why it was created. And of course, these things are present in multiple things, in cereals, in fruit and vegetables, and in dairy products, but meat doesn't have them. And they're at variable levels. There are other FODMAPs there, the ones that that are the most common, but there are other ones in the diet. Xylose is something which you might remember historically from a xylose tolerance test. That's behaves like polyols, but is not really much in food. Xylo-oligosaccharides are more in fermented foods in Eastern Asia and not much in our food supply. But there are synthetic and pharmaceutical agents. You heard all about lactulose before the break, and that's a FODMAP. Prebiotic oligosaccharides like galacto-oligosaccharides, xylo-oligosaccharides, fructo-oligosaccharides are being put in food for their prebiotic benefits. And inulin has been something which I've been amazed at how much is put into the American diet as a fermentable fibre. And of course, that behaves exactly like a FODMAP. The other one that's just happened is probably there's going to hear a lot more about it, is that in some people who have a relative inactivity of their sucrase isomaltase enzyme in their brush border, that they may not digest sucrose quite so well, or starch oligosaccharides, which is the product after amylase digestion. So in some people this might be a case, but this is an area that's being sorted out now, and there's some evidence that it might be important in the future. Now, the major mechanisms, I'd just like to reiterate that what we're talking about here is something which happens in all of us. This is not something specific to IBS. And what happens is that if you get oligosaccharides, will not be digested. We have no hydrolases to digest them, so they all go through to the large bowel. By the way, that's the small bowel and large bowel, and those funny things there are bacteria. And we're very good at science in Australia, not so good at drawing. But if you take lactose and it's not digested, it will go straight through, whereas polyols and fructose, they're very slowly absorbed down the small intestine and stay in there. They're very small molecules, luminally active, osmotically active, so that they will drag water into the bowel wall, into the bowel lumen, and will distend. That water, of course, will move into the large bowel. All of these things are very fermentable. They're like McDonald's to bacteria in the bowel, and you get nice production of gases. And so the idea is that this will cause luminal dissension. That'll happen in all of us, but if you've got visceral hypersensitivity, then this will induce pain, bloating, gas and diarrhoea. Now, does it really work? Well, the low FODMAP diet was designed as a three-stage thing. The first stage is where you're really trying to find out whether someone is sensitive to FODMAPs. And so you avoid all foods high in FODMAPs and replace them with foods low in FODMAPs in each food group. And in fact, that's where one of the things we've been doing over many years is measuring FODMAP content in food, because there are not good lists around the world. Most of the lists come from us, and that's what's present in the Monash University low FODMAP diet app as a resource for this. We would do this for, say, 2 weeks, 3 weeks, 4 weeks, 5 weeks, whatever you can, whatever is suitable for seeing them again. You would, but if there was no benefit for the patient and they were compliant to it, then you would stop. You they don't need that sort of therapy. If they have efficacy, which we would see in about 75% of people, that we would then go to the second phase, which is a step down according to tolerance. So basically you stay low FODMAP, but you just try individual foods have individual FODMAPs in them, and then work out what your sensitivities are, what dose you can tolerate, and then you move into the personalised phase, which is where you just put all this together, and it really is a long-term therapy. Now, the first phase, does it work? Yes, there are many randomised controlled trials. There are problems with the trials because they all have different comparators. The first study up here was a feeding study, which was the major study that we did. It was very important because it's a very tightly controlled study where we fed 30 patients with IBS and a few healthy controls and a few people with Crohn's disease a typical FODMAP diet or a low FODMAP diet, and crossed over after a bit of a washout. And this was 30 people fed for 3 weeks with one diet and 3 weeks another, a gargantuan effort, and it showed a clear differentiation in symptoms in with the two diets. A Canadian study compared it with high FODMAP diet, British study with the habitual diet. This is the Michigan study of Bill Shea's group from Chantiers Warren, showed that the modified NICE diet, which is one of the sort of more lifestyle diets from England, they showed it improved that in IBS-D. And then there was a really important study from King's College in London, which was against a true placebo diet and showed benefit. And if you can put all these together in a meta-analysis, not a great meta-analysis because the comparator is different, one arm's the same, but you can see that the diamond at the bottom sits on the right side and is convincingly efficacious. Now, phase 2, as I said, the reason for this is we really want to identify what people are sensitive to, and that the sensitivities are different. Some people are very sensitive to fructose, many people are very sensitive to fructans, some people to galacto-oligosaccharides and others not. And so the idea is we want to have the least amount of restriction in the longer term, and this is an important phase. And the process is where we challenge one at a time, build up, like for instance, if for fructans you would try 1 onion ring, and then the next day have 2 onion rings and see whether you get symptoms. It's that sensitive the people are to fructans. And then you go on to phase 3, and what we're aiming for is a mild restriction only, with where eating is no longer a burden as it is when you're in the strict phases, and they restrict according to the specific FODMAPs that seem to be a problem and the dose. And this is where patients really feel empowered, because they can increase and decrease their restriction, and they know how to do it according to how their IBS is going. Because these things are not causing IBS, the visceral sensitivity is there, they're just reducing the manifestations in terms of symptoms. The other thing that we've found extraordinarily useful is that the patients no longer come to accident and emergency with severe abdominal pain after they've had the wrong meal the night before, and they understand why they get pain, and a lot more reassurance. Does this work? Is it any good in the long term? Is this just a honeymoon period? Well, there are now 6 prospective studies. Very hard to do randomised controlled trials, almost impossible here. So it has to be prospective observational studies. And what's been found is the follow-up has been 3 to 18 months after de-restricting, and 75% of people have been able to reintroduce to the personalised diet, and overall sustained response has been 57 to 82%. I'll just show you some data from one study from New Zealand, where you can see that the FODMAP intake here during the baseline was that it reduced markedly when you went on to the low FODMAP phase 1 diet. The symptoms went down markedly, and what they found was that the fibre intake also markedly went down. Not all studies find that. When they went into the personalised diet after the re-challenge phase was over, you can see that the FODMAP intake has increased. Still not up to where it was, but it's increased. The symptoms have remained similar. No differences in the symptoms, and the fibre intake has gone back to normal. So what we have achieved with that is continuing symptom control, less FODMAP restriction, and nutritional adequacy maintained. Now, can we predict, if you're going to do this to people, can we predict who's going to get it? Because it's an investment in health professionals' time and patients' time. And what are not predictors are bowel patterns. There's been a rumour going around, I don't know where it came from, that this diet only works in IBS-D. It works in all of them. And that's in the literature, there are data on this. although no particular study has looked specifically at IBS-C or specifically IBS-M, but that's, I don't think that is ever going to be done. Breath hydrogen patterns after fructose and polyols and things, yeah, they're very good at making money, but they don't really predict who's going to respond to the diet because they don't tell you anything about the distension of the small bowel, which is one of the sites of genesis of symptoms. There have been one group in Switzerland who claimed that the symptom response during breath tests rather than the hydrogen response are predictive, but that's quite a difficult one to actually tease out. It hasn't been done prospectively. And then there's been a lot of interest in actually if you can get a poo sample and you can work out what the microbiota are, you can predict who's going to do well or who isn't. And I'd just like to mention this because this is something which is being sold, and I think probably a little bit prematurely, that this is the GA test, which is like a microarray where you compare the patient's microbiota, compare it to 100 healthy controls from Norway. And what you do is you get this dysbiosis index. But if you look here, this is one way of doing the analysis. And you can see here, there's all these people who responded with the open circles are all sitting out here with only one non-responder there. The trouble is that there's such a big overlap and all these responders here, if you use this test to not give them the diet, it would be a real shame that they weren't offered it. One of the really exciting ones was where we just, you know that the dogs can sniff poo, can sniff faeces and diagnose bowel cancer. Well, having dogs around is really difficult, very hard to have that in your practice. But there are machines that can measure it with chromatography. And this particular study of the King's College a randomised controlled trial showed that they could separate the responders from the non-responders by getting a certain pattern. And it's really exciting if you can do that because it's a simple test, not too expensive, and the trouble is it needs to be done. It may not work in the next group of patients. You might have to have a different pattern. Now, you have to know about risks, if any, of these things in the diets. There's always the psychosocial consequences of being on a diet, and you might be precipitating or at least exacerbating disorders of eating in the vulnerable. Orthorexia, this obsession with healthy eating, not a DSM classification, but is very common, and this is just sort of stretching it. You know, they're no longer on gluten-free and organic and having only separating things, but also now the low FODMAP. That's not a good combination. In nutritional inadequacy, we always worry about with any restrictive diet. Calcium and fibre seem to be at most risk, but in fact, several studies have not shown that as a risk, and in the longer term, these things all improve, and I showed you some data on that. The thing that has disturbed a lot of people are data on the effect on the gut microbiome. On the microbiota, are we creating dysbiotic bacteria? And in fact, you don't change the diversity. Bifidobacteria reduce because it's not surprising since you're taking the food away from them. But you can correct that with a probiotic if you think that's important. And there was data from our detailed study, which I don't have time to show you, but where perhaps people have said we're taking prebiotics away and you're getting loss of butyrate-producing bacteria and other things. The only thing is that this was probably a misinterpretation and we don't believe that happens. And certainly after a personalised diet, the only study that's been done so far has shown no change in microbiota. Now, one of the problems with it is, are gastroenterologists interested in doing this? And first of all, it's in guidelines. Okay, the ACG guidelines have a recommendation for using it. Secondly, do gastroenterologists in the US use diet? And Bill Shea did a survey of 1,562 gastroenterologists across America, answered the survey, and more than 75% of them recommended a dietary therapy to their IBS patients. But the most disturbing, that was great, but the most disturbing thing was that only 21% of those referred patients to dietitians, so the gastroenterologists are managing diet, which is which is probably not a great idea given our training in dietary things, and less than one out of three of those were GI dietitians. And this is the sort of pattern of, most people were just not using a dietitian. Do you need one? This has been a big issue because what does a dietitian offer? Well, they offer, most of the evidence comes from this setting, dietitian delivered diets. They maintain nutritional adequacy because this is what dietitians do. They don't want people to, if they're going to change their diet, they want them to have a nutritionally adequate diet. I think that the reintroduction phase is very important and is much better managed by the dietitian. Dietitians are wary of those with risk, at risk, or who have disordered eating much more than gastroenterologists, and those that probably are not suitable for diet. They can deal with practical issues. I haven't met a gastroenterologist who's particularly efficient at telling patients how to read food labels, how to plan meals, and and about recipes. But the dietitian, of course, needs to be adequately trained and equipped as well. So is this all just sort of just a plug for dietitians without any evidence? Well, there's some evidence. This was a poster at DDW. Hasn't been peer reviewed as yet, but this was done by a dietitian who is doing a postdoc there, who did a PhD with us, and she looked at 80 patients attending a gastro clinic in Canada. And she retrospectively reviewed them. They'd all been previously recommended a low FODMAP diet, and these were the results that she found. The overall improvement in their symptoms was no significant difference between 24 who'd seen a dietitian and 56 who hadn't. And there was a difference here numerically, but it wasn't significant. And you would say, well, you don't need a dietitian. However, when she looked at all the appropriateness of the diet and whether it was being done optimally, it's like using a drug but using a too low a dose or not measuring infliximab levels, these sorts of things, it's not optimal. You find that the appropriate implementation in the various phases was really, really very poor compared with the dietitian. So, that's one thing that you can do. What about psychological therapies in IBS? Why were we interested in those? Well, there's good evidence for efficacy and they improve all the symptoms and quality of life. It's of course difficult to get high quality data because of the designing a blinded placebo is quite challenging. They are currently, generally, I find that they're being used as a rescue for people with perceived psychological comorbidity, but there is evidence that they might actually, their efficacy is independent of the psychological status of the person. Now, if you want to look then at what approaches there are lots of approaches, and these have all been studied in IBS. And there are lots of things, and these are active therapy. We're not talking about counselling here, we're talking about active psychological interventions. And there have been lots of studies done, and this was a meta-analysis from Alex Ford in 2014, so there have been more studies since, and there are lots of studies of cognitive behaviour therapy, relaxation training, hypnotherapy, and there's also been several studies on online or self-taught therapies, although they don't seem to perform as well as the one-on-one therapies. We're very interested in gut-directed hypnotherapy, and we asked the question, how does this compare with low FODMAP diet? We assumed low FODMAP diet was efficacious, so we just did a trial where we took people who were relatively undertreated. They weren't our heart sync patients from the clinic. They were people who hadn't been through the mill, and we did the hypnotherapy of 6 weeks using the Manchester type protocol, and they did just as well as people with low FODMAP diet. and here's the visual analog scale of their overall symptoms, and at 6 months they maintained this very well. It was about 70% of people who had a clinically significant improvement. And Simone Peters, who did this as part of her postdoctoral training, she thought that she wanted to show that they did better psychologically, and yes, they seem to at 6 months after hypnotherapy, they seem to be better, at least on the hospital anxiety depression scale. So this study suggested that when applied as a primary therapy, that it's as effective, gut-directed hypnotherapy is as effective as a FODMAP diet, shorter and longer term, has additional psychological benefits, but didn't seem to be additive if you do the two together. So it may be not a rescue therapy, but a frontline therapy. And in fact, now there's a study with yoga showing a very similar results, that yoga can do as well as the diet. So we've got these psychological therapies, we've got dietary therapies. How do we make the choice of what to use? Well, the availability of expertise is important. You can't do hypnotherapy without a gut-directed trained hypnotherapist, and you need a dietitian, really, although not necessarily. You have to have patient buy-in, and funding and insurance comes into this quite a bit. You have to be aware of current comorbidities which might lead you to one rather than the other, or the risks of specific therapies. You'd never do hypnotherapy in someone who is psychotic, for instance. And are they cost effective? Well, this is another study which has not been peer reviewed, but was a poster at DDW from Eric Shah, who did this work with Bill Shea and with us. And he looked at the cost effectiveness from a payer perspective and patient perspective. The cost goes up, and this on the y-axis, and the effectiveness goes up as you go to the right on the x-axis. And you can see here that CBT, cognitive behaviour therapy, and low FODMAP diet were way ahead of the others. Tricyclic antidepressants were very cost effective, although not quite as effective in terms of the quality gained. And the same sort of thing happens in the patient perspective, there were similar results. So I would say that my take-home messages are that non-pharmacological strategies are rational and efficacious. Of the dietary strategies, the FODMAP strategy is a dynamic dietary program, provides evidence-based efficacy for most symptoms, and is cost-effective, at least for IBSD where the study was done, but we await further work in that area. Of psychotherapeutic approaches, they have a moderate level of efficacy for several techniques, which have been shown by a number of studies and have benefit for all symptoms and for psychological health, and also in this preliminary evidence seem to be cost effective. All approaches, of course, should be delivered by skilled health professionals, because that's what this database, what the evidence base has been built from. And personalised therapy is the rule, because you consider the risks versus likely benefits for each person. Now, I'd just like to self-indulge a little bit here, just to say what I think is happening to IBS. IBS is a very exciting time in IBS. When I trained, the therapy was placebo, drugs, diet. We used to throw the patient to the dietitian, say, increase the fibre, decrease the fibre. The patient had never come back happy, and the dietitian was equally unhappy. And we would use psychology and psychiatry to rescue our patients. And this was owned by neurogastroenterologists. If you weren't doing well, you'd find a neurogastroenterologist. In 2019 and in the future, we still use placebo, very important, but diet and psychological therapy, at least in our practice, is now frontline. We have all these adjunct means of fine-tuning for patients. We still rescue patients, but I think the most important message of this slide is that it's a multidisciplinary action now. That now it's owned, IBS is owned by dietitians, by general gastroenterologists, by neurogastroenterologists, by psychologists, by nurses, and so on. So that it becomes it's become a much nicer thing to manage, and much more effectively to manage it. Thank you.
Well, thanks, Peter. To make a bad pun, you gave us lots of food for thought. Okay, remember to jot down your questions and we'll deal with them in a little bit. But first, we have another talk for you, and this is by Dr. Andres Caron, who is Assistant Professor of Clinical Medicine at the University of Miami, Miller School of Medicine, nearby in Miami. So Andres, please.
Thank you so much for staying, and thank you for the invitation to the organizers. My task for the next 30 minutes is to provide you a clinically meaningful review of pancreatic cystic lesions and their potential for malignancy. And as you all know, all of you that do clinical practice, we encounter this problem essentially on a daily basis. To start with, pancreatic cystic lesions are extremely prevalent in the general population. There's some populational studies that suggest that the real prevalence may be somewhere between 3 to 15%, but there is a significant variation depending on the age group that you analyze it. And obviously this becomes much more prevalent in the elderly. Now the real prevalence may be significantly higher, and we've learned this based on high-resolution MRI or high-resolution CT scanning. Now, endoscopic ultrasonography has also driven up the prevalence significantly, because now we're able to basically visualize the pancreas just from a few millimeters away. So there's some studies that suggest that actually this prevalence may be up to 50% if we take the general population as a whole. What's important is, and we all know this, that most patients that present with cystic lesions in the pancreas are completely asymptomatic, and usually that diagnosis is made incidentally because the imaging study was ordered for a different reason and just happened to pick up something in the pancreas, and now the patient is being referred to you or me for further evaluation and management. These lesions can be 100% benign. They can be 100% malignant to begin with, or they can have a potential to transform into malignancy in the future. And I think the latter point is what's important, and that's usually where the patient ends up in your clinic to determine what to do and what the surveillance strategy will be appropriate for each individual. There's a populational-based study that followed about 1,000 patients for approximately 5 years in Germany that was trying to determine if there are any particular risk factors for pancreatic cystic lesions, not for pancreatic cancer, but for cystic lesions. And basically, increased BMI appears to be the only one that is actually relevant after adjusting for age. Diabetes was significant, but when adjusted to age and BMI, became non-significant. And the other part that's important is to look at the relative risk for BMI, which is only 1.017. So the increased risk is actually extremely low, even for the only significant risk factor for this type of lesions. Now, there are many subtypes of pancreatic cystic lesions out there, and we're going to pay attention to the top three, which are serous cystic lesions, mucinous neoplasms, and intraductal papillary mucinous neoplasms. But I'm also going to talk a little bit about simple cysts, because it's usually a common question, because we do see simple cysts in other organs, and a lot of people wonder what's going on with simple cysts in the pancreas. So you'll hear a little bit about them in a few slides. The clinical characteristics of these lesions is extremely important, because if you know this table, you're going to potentially make the right diagnosis up front. There's a male to female ratio that we must remember. Serous neoplasms and mucinous neoplasms are significantly more common in women. IPMNs are much more prevalent in males, 2 to 1. And pseudocysts, which usually happen in the setting of chronic pancreatitis or following episodes of acute pancreatitis, are equally distributed. The location of the lesion is also important. And as you see, serous and mucinous lesions are much more common in the body and tail of the pancreas. IPMNs, on the other hand, are more common in the head, and pseudocysts can be anywhere in the pancreas depending on where the disruption of the duct occurs. And then an important part has become fluid aspiration, and this can be done with endoscopic ultrasonography. Now, the endosonographer is always going to send the fluid for a few things, and CEA is one of the most important ones, because that helps to determine if the lesion is a mucinous or not, and high CEA levels in the fluid help us make a diagnosis of mucinous lesions. Other things like mucin stain, amylase are actually important, but if you have to take home one message, think about the CEA and the fluid, and when it's elevated, that will be potentially a mucinous lesion. So I'm going to be talking about some of the commonest lesions, and IPMNs, or intraductal papillary mucinous neoplasms, are classified into 3 categories, depending on the location. If it affects the main duct, it's obviously called a main duct IPMN, and usually is diagnosed when the pancreatic duct diameter is greater than 5 millimeters. These are lesions that are extremely high risk for malignancy, and you'll see the data in a few slides. Branch duct IPMN is the commonest lesion that we find in the pancreas, about 60%. They're usually completely indolent in their natural history, and about 10 or 15% of them will enlarge over the next 3 years or so. Their potential to malignancy is relatively low, and if the patient is symptomatic, that will drive up the risk of malignancy. And mixed IPMNs are basically a combination of the previous 2. And the risk of malignancy is obviously determined by the main duct component. The Fukuoka guidelines that were published several years ago basically provided a very nice risk stratification for these lesions. And the 3 components that must be taken into account include the size of the lesion, the mural nodules or solid component on these lesions, and dilation of the main pancreatic duct, which I already alluded to. When we look at main duct IPMNs versus branch IPMNs, we can see that the malignant potential is extremely high for the main ducts, and malignant potential for branch duct IPMNs that are actually considered high risk, the ones that are greater than 3 centimeters usually, it's high, but not as high as the main duct. So it's something that we have to take into account. Main duct IPMNs are an indication for surgical evaluation immediately. Branch duct IPMNs is something that you have to individualize a little bit, and we'll review the data in a few slides. The other type of lesions that are important and relevant in clinical practice is the mucinocystic neoplasms, or MCNs. And these are more common in the tail and body of the pancreas, as it was alluded earlier. They are predominantly occurring in women and usually middle age. They have ovarian stroma surrounding the cyst cavity, and they have some relation to sex hormones. There's usually no communication with the pancreatic ductal system at all, which differentiates them with branch duct IPMN, which has a direct communication with the pancreatic ductal system. And then this can have any degree of dysplasia from low to high, or harbor carcinoma already. The features that convey high risk for mucinocystic neoplasms include symptoms. If the patient develops jaundice or pancreatitis due to the lesion, this is already considered a very high-risk feature for malignancy. If we find elevation of the CA99 in the serum, it's also considered a high-risk malignancy. Now, that's given that there's no biliary obstruction or other significant problem that's driving the elevation. On imaging studies, there are important features like mural nodules or enhancing a specific part of the wall. Size, as I mentioned before, is extremely important, and 3 centimeters should be the cutoff to determine sort of low risk versus high risk. And obviously, if the endosonographer aspirated fluid and this fluid was positive for dysplasia or malignancy on cytology, that will convey a very high risk for malignancy. The other type of lesion is the serocystic adenoma, and this is significantly more common in women, as you see, and it typically has a microcystic component with a central scar. In the image, you can see the central scar that's not enhancing. In MRI and CT scan nowadays are extremely accurate to pinpoint even fine details such as that non-enhancing central scar, to the point that the radiologists can put a name and last name to these lesions with actually good accuracy. The risk of cancer for this type of lesion is almost negligible, and majority of reports reported from 0 to 0.1%. So it's something that it's completely benign and usually requires no additional follow-up or intervention unless the patient is symptomatic from this particular lesion. And as I promised, simple cysts, I'm going to talk just one slide. These are like simple cysts that you see in the liver or the kidneys, for instance. However, they're extremely rare in the adult population, and they're actually more common in children. So it's thought that as children grow, the cysts disappear. So childhood is one of the risk factors. Other diseases like polycystic kidney diseases, either autosomal or recessive, are risk factors. And other syndromes like bone Hippo-Lindau, for example, will be associated with simple cysts. But in the general population, you're not going to find that many simple cysts in adults or the elderly population. They're going to be primarily the other types of lesions that we mentioned before. Now, these lesions, as for example, liver cysts or renal cysts, usually have absolutely no potential for malignant transformation, so follow-up is not indicated if these are discovered. So what's the clinical approach when we actually get a patient with a pancreatic cyst? So we are usually not the ones that diagnose them or find them in the first place. Usually we get a patient referred for an opinion on what to do. So there has been already an imaging study, be an ultrasound, a single-phase CT, or a non-contrast CT, for example. Our task is to do a detailed history and physical, as always, and try to pinpoint any risk factors, like previous episodes of pancreatitis, for example, that will lead us towards a pseudocyst diagnosis. If there's any family history, if there's signs and symptoms, as I mentioned before, is extremely important, because the presence of obstructive jaundice, for example, conveys high risk for malignancy. Then we'll do routine blood work. There's nothing special to do for these lesions, but it's always recommended to throw a CA-99 level on the mix, especially if there's no biliary obstruction. If there's biliary obstruction, the CA-99 level becomes a bit confusing. And then we have to do dedicated imaging studies, and in 2019, multiphasic CT or MRI with and without contrast, with dedicated cuts and fine cuts to the pancreas, is the way to go. MRI obviously is preferred because of the absence of radiation, but you have to be mindful that some patients may have difficulty holding the breath or staying in the supine position for long periods of time. And second-line imaging slash diagnostic modality will be EUS. And the guidelines, the current guidelines, make it clear that MRI should be the preferred modality, even though we see more and more that EUS is being used as a frontline therapy, but MRI is more cost-effective. So a study from several years ago compared actually the accuracy of these three diagnostic modalities. And as you can see, MRI performs really well. EUS does have advantages, but we have to think of it as a relatively invasive test, because we're going to put the patient under anesthesia, and most of the times the endosonographer actually will put a needle through the stomach or the duodenum into the pancreas, which also carries some potential risks. In contrast, MRI will have pretty negligible risks. The contrast injection is pretty much the only risk factor, so MRI is still the preferred, and it actually produces extremely detailed images that allow us to see communication with the pancreatic ductal system, which can be difficult to ascertain with endoscopic ultrasonography. So overall, the accuracy of the currently used imaging studies was assessed in about 300 patients with cystic lesions. And as you can see, for main duct IPMNs, we have an overall accuracy of about 94%. And this is using MRI, EUS, or CT. MRI is an excellent test for main duct IPMNs. Usually you request an MRI with and without gadolinium, pancreas mass protocol with MRCP sequences, and you'll get pretty much all you need in one study. Serous adenomas can be diagnosed with either test, CT or MRI. Both are highly accurate. They're going to be doing thin cuts through the pancreas, and that central scar will be very evident on either test. Branch duct IPMNs are a little bit more difficult to diagnose, and only 2/3 of the time. And EUS and MRI are the main players there. CT scan is not a very useful test for this particular lesion. And mucinous cysts can be visualized with either CT or MRI very accurately. And obviously, EUS will provide the advantage of sampling the cyst and getting that elevated CEA level on the fluid. The overall accuracy for all these tests and for all lesions in the pancreas, cystic lesions, is about 68%. So that's why sometimes combination of two modalities may have an important role. So now, what's the risk of malignancy when we take pancreatic cystic lesions, and particularly mucinous lesions, which are the higher risks? So we should know that incidentally discovered cystic lesions actually have a very low risk for malignancy, which has been studied based on retrospective reviews, 0.01%. So that means for every 1,000 patients, we may have one patient that is at risk for pancreatic cancer. Now, most people argue that pancreatic cancer is such a devastating diagnosis that it's worth being extremely proactive and try to identify which people are going to be at high risk. So what are the predictors for malignancy? And we mentioned already size, 3 centimeters at least. Solid component or enhancing component within the lesion is something that should catch our attention. Dilation of the main pancreatic duct, 5 millimeters at least, and that usually signals a main duct IPMN, or mucinous cystic lesions that are at least 3 centimeters as well. So what's important is that if we take a patient that has even a strong family history of pancreatic cancer, the finding of a pancreatic cystic lesion itself is not going to increase the risk of pancreatic cancer. The risk of pancreatic cancer is not being driven by the IPMN, the branch duct IPMN, or the mucinous lesion. It's driven by other genetic variables. So we have to pay attention to the lesion, but we shouldn't put that patient at a high-risk category just because there's family history of pancreatic cancer, because the pathways are completely different. Now, when we take main duct IPMNs, the risk of pancreatic cancer is high, so that's why those patients should be channeled directly to surgery. Branch duct IPMNs, as you see, there's significant variability from 8 to 50%, so this is when our clinical instinct should play a major role, and we need to stratify those patients into low and high-risk categories. And for mucinous lesions, we still have to do that because the risk is up to 34%. So even assuming that all cancers will arise from a pancreatic cystic lesion, the probability of malignancy is quite low, 0.25%. And the rates of invasive cancer are 0.24%. And this data came out of the SEER database analysis that looked at several years combined. So what do we do with regards to surveillance? Surveillance is something that needs to be discussed up front with the patient and make sure that the patient is buying into this approach. Patients that are not fit for surgery should be ideally excluded from surveillance protocols because we're not going to do any favor to that patient if we're doing MRIs every 6 to 12 months and we actually find something that needs to be operated on, the patient says, well, I never wanted surgery to begin with, or the surgeon says, I can't operate because his heart function is 10 or 15% or something like that. So surveillance only for patients that are fit for surgery. And again, looking at the risk of malignancies, we're going to start narrowing down what are we going to do and how often are we going to do for specific lesions. So surveillance is indicated for mucinous lesions and IPMNs because the risk of malignancy is significant, but is absolutely not indicated for serous adenomas or for pseudocysts. When we do surveillance strategy, MRI should be the way to go. EUS, if it's a very nice modality, sampling is always an add-on, but cost effectiveness, MRI wins by far. Then we have to do an individualized approach in our 65-year-old patient that we've been following up for 10 years, and now is hitting 75 and may not be such a great candidate for surgery anymore. So during every visit, we have to reanalyze the situation and determine if the patient is still a surgical candidate and if surgery is something that he or she will be ultimately interested. So the ACG guidelines have put up this detailed algorithm, and I'm just showing it up here. If you Google the ACG guidelines from last year, you'll find it. And every time you need it, you'll have to go back on it because it's almost impossible to memorize so many points here. But the bottom line is that MRI every so often will be the way to go unless you have a patient that's already presenting with a very large lesion over 3 centimeters that should be considered during a multidisciplinary approach for potential surgery. So again, this is from the guidelines from last year, and you can refer to that every time you need it. What happens to cysts over time? There's a very nice study from Germany, again, that demonstrated the majority of cysts actually remain stable or increase in size over time. So as we surveil these patients, we're going to notice that the cysts are growing, and that's usually a worrisome feature, as you'll see in a few minutes. But the number may also increase. So instead of having 1 or 2, now next time you do an MRI or 2 years down the road, you may find 3 or 4. And it's something that you have to keep in mind, that the natural history of these lesions is to increase in size and number. What are the indications for surgery, particularly for IPMNs? They're absolute and relative indications. And again, this is something that needs to be discussed with the patient. Absolute indications include a positive cytology. You've got enough evidence that there's high-grade dysplasia, for example, or cancer. That patient should be operated on. If there's a solid or an enhancing area on the imaging study, that should be taken very seriously, and the patient should be expedited for surgery. If the person developed jaundice as a result of the lesion, now if the lesion is in the tail of the pancreas and the patient has jaundice, then you got to think about something different. But if the lesion is in the head of the pancreas, near the intrapancreatic portion of the common bile duct, and the person is having jaundice, then the two things are linked. If there's main duct dilatation greater than 10 millimeters, that is absolute indication for surgery. If the main duct, in contrast, is 5 millimeters or so, then you can consider that a relative indication, but most experts favor surgical resection if the patient is a candidate. And as you see, there are other variables, including CA19-9, that will play a role in the relative indications. Post-resection surveillance. So once the patient has undergone surgery and is coming back to your office to figure out what to do next, there's some patients that will require surveillance. So when it's not indicated is in pseudocysts. So number one, you shouldn't have been surveilling a pseudocyst to begin with. If the person gets a cyst gastrostomy, you don't need to be surveilling that cyst, particularly for malignancy. You can surveil it for recurrence, but you don't need to worry about malignancy because there's no malignant transformation. For cystadenomas, as you saw at the beginning, the rate of malignancy is extremely low, so you're not going to be following those patients, and you rescanning or re-imaging only if there are new symptoms that you may think are attributable to the lesion. Now, for mucinous lesions with low, intermediate, or high-grade dysplasia, there's no surveillance post-resection either. Those patients get operated, resection, done. You don't have to follow it up. And other benign cystic lesions like simple cysts, if for whatever reason the person got a resection, which shouldn't have happened, no surveillance is indicated. But all patients with IPMNs that undergo resection need surveillance post-surgical. Mucinous lesions with cancer also should be surveilled because of the risk of metachronous lesions. And solid pseudopapillary neoplasm of the pancreas, which is a special type of tumor of the pancreas, should be surveilled post-resection as well. So that's making it easy. IPMNs that go for surgery get surveilled post-surgical, and mucinous lesions with cancer. All the other cystic lesions that you saw before don't get any surveillance post-resection. Now, when do we discontinue surveillance of these lesions? Usually when there's no or there's minimal change over a 4-year period of time. This is supported by the latest ACG guidelines from last year. When patients become inoperable for whatever other reason, so you should stop it right away. After 75 years of age, there's a strong recommendation to consider stopping it because of the nature of the lesions. It's not going to take 1 or 2 years to transform malignancy, but rather 5 or 10 years usually. So you should consider stopping it. Now, in a nutshell, indications for surgical resection, just reviewing this, main duct IPMNs, all surgically fit patients should be referred to a surgeon that has expertise in pancreatic surgery, and hopefully that gets taken care of. Branch duct IPMNs that are at least 3 centimeters in size, that have mural nodules or are symptomatic, should be resected. Mucinous cystic lesions, if the person is a surgical candidate, consider resection. If you're going to provide follow-up, then the ACG guidelines from 2018 will provide you what to do based on the size of the lesion. If it's 1 centimeter versus 2 centimeters versus 3 centimeters, and obviously if it's more than 3 centimeters, patient should be surgically evaluated right away. Solid pseudopapillary lesions, if you happen to find this and the radiologist is confident on the diagnosis, or there's a biopsy that supports the diagnosis, person should go for surgery automatically. And serious cystic lesions only if symptomatic, otherwise leave them alone, and sometimes can be hard to attribute the actual symptoms to the particular lesion because, as you all know, there may be several confounders. So the take-home points: asymptomatic, incidentally discovered cystic lesions of the pancreas are increasingly diagnosed, and you saw that some reports suggest that even with high-resolution MRI or CT or EUS, we can be picking it up in up to half of the patients are undergoing these studies. These are more common in the elderly, except for simple pancreatic cysts, which are more common in childhood. The malignant potential varies dramatically depending on the type of lesion, so it's important to put a first name and last name to the particular lesion. It's important to do it at a place that an MRI or CT scanner are the latest generation, and you have a radiologist that will be confident on putting a diagnosis there on the report. There's no malignant potential for some of these lesions at all. Therefore, follow-up surveillance is usually not indicated. And there's malignant potential, particularly in lesions that are large, 3 centimeters or greater, if the lesions prove to be mucinous, or if there's a solid or enhancing component in the imaging study, or the pancreatic duct is dilated. Surveillance should be indicated only for surgical candidates, and those groups should be branch duct IPMN and mucinocystic lesions. The other ones don't require follow-up. Surgical resection, again, main duct IPMN, automatic. Mucinocystic lesions, all patients should be considered surgical candidates, and then if you want to stratify, use your size, the 3 centimeters or greater, as a cutoff. Post-resection surveillance, for IPMNs, there's a typo there, and mucinocystic lesions with cancer, not any mucinocystic lesion. Once you've resected a mucinous lesion, even with local-grade dysplasia, you're done. That person does not require subsequent follow-up based on available evidence. And solid pseudopapillary lesions are a complete different ballgame, but those should be surveilled post-surgically.
Let me start out with a question. I have to commend the question writer for very neat handwriting. It's a great premium for a moderator to have someone who writes very neatly. Dr. Gibson, what are your recommendations on getting the patient to buy into diet and psychological therapy? I find that many of our patients are set on medicinal therapies and are unhappy when other options are brought to the table.
Unhappy when they are. Well, I'm very surprised. I think that's the bias of the person asking the question, because if you discuss it with patients and say, right, we can put you on a drug, may help 1 or 2 of your symptoms. It only works as long as you take it. It's going to have to take it for, you're going to have this for a long time, and then suggest that you might be able to do other things like changing the sensitivity of your bowel with psychological therapies, using the brain to change things, or just choose foods a little bit more wisely. I find that we have no difficulty because perhaps it's because our reputation of our clinic is to minimise drug use, but you know that's where you've got to tailor it to the patient. It's all about individualisation. That if they are they just want a quick fix with a drug. A, we don't have one, and B, you know, you have to go with the patient. But I think you should still be introducing it. But it's not something you can introduce in a 5-minute consultation.
Yeah, well, that may be a national issue because the United States, and I think one other country in the world, allows direct-to-consumer advertising, and that's done by people selling the medicines. And the end of the thing is ask your doctor about such and such, and then they go through a zillion side effects that the drug has.
So perhaps we should have a national advertising campaign. Ask your doctor about about a FODMAP diet.
Maybe so. Okay. Next question for you, Dr. Gibson. You had the lion's share, as one might have predicted. How to diagnose carbohydrate deficiency? And I imagine you're talking about enzyme to digest the carbohydrate deficiency.
Well, the only one that that's got evidence base for diagnostic tests is lactose with lactase deficiency. Breath tests, blood tests, genetic tests have all got evidence of being beneficial, and also dietary trials with reintroduction can also do it. I think when you get to the other brush border hydrolases, like the sucrase isomaltase, the evidence base for it is very poor. You can measure enzyme levels in biopsies, but that's all been sort of validated in children, not in adults. Breath tests, sucrase breath tests have got more problems with them than you can imagine, and maybe genetic testing is a way to do it. But this is something that needs study, is being studied currently. And so I don't think we should be pursuing that. The other problem I would say about if you are very interested in sucrase isomaltase deficiency or relative deficiency as a cause, the dietary management of that is really, really difficult. You've got to reduce sucrose as well as starch, and that becomes a very difficult. Maybe they all got to go on a keto diet, which I wouldn't be recommending.
Okay. Andreas, this one's for you. It says, do you routinely do EGD and EUS or EUS alone? If so, is there a CPT code for EUS alone? And this person is interested in CPT codes too. Is there one for FNA and FNB, or are they the same?
So the latter part, FNA, FNB is under the same CPT code, and for the two procedures versus one, it basically depends on the note. If you do a note for EGD and a note for EUS, you can get reimbursed half for the second test. But if you include it all in the same note, you get basically paid for EUS, not for EGD.
Okay, and Dr. Gibson, another question for you. Question about the role for diagnostic testing for small intestinal bacterial overgrowth in these patients.
Well, if you want to divide a room of gastroenterologists, you just start talking about SIBO. The tests, I think it's much cheaper to get a coin out of your pocket and toss it to whether they've got SIBO or not, and the ability of glucose breath test to demonstrate SIBO is very poor. Lactulose is very, very poor. And I think you're better off, if you think they could have SIBO, to give them a trial of rifaximin if they can afford it, and see whether they have a response. The other thing is that SIBO is it's a wonderful, I love the concept, but it's really hard to know where it fits in. It might just be a normal event. And theoretically, low FODMAP diet should really help SIBO, because bacteria in the small bowel, their major source of energy is short-chain carbohydrates, which you reduce in the low FODMAP diet.
Okay, there was one question for me, just so you don't think I was left out. It says, which tricyclic do you use the most? And the answer to that is probably amitriptyline, because I see mainly people who have diarrhea, although some people with constipation. And I like that drug, even though it has more anticholinergic effects, because it has more anticholinergic effects. And that does two things when we give a bedtime dose. One is it slows down their intestine a little bit, which makes it easier to get to sleep if you have diarrhea. And it also is sedating, and sleep disturbances are rife in patients with IBS, even though they don't particularly wake up at night with their symptoms. And so I think it helps give them a sounder sleep and do better. If someone has more constipated IBS, then I think using some of the alternatives with less anticholinergic effect makes sense, but again, in the low doses, I'm not sure it's that really important when you get down to it. Okay, this is another good question for you, Andreas. What is the recommendation for family members with one first-degree family member with pancreatic cancer? Should someone take a look at their pancreas with some technique?
Right, so this is a different question than pancreatic cystic lesions. Remember that the family history of pancreatic cancer does not increase the risk of cancer in the person that has a cyst, but the person is at increased risk for pancreatic cancer independent of the cyst completely. This is an evolving field, and we and other centers are doing a little bit more proactive approach in screening family members in various ways. One, you can do genetic testings and try to figure out the genetic profile of usually the patient that has the cancer and see if there's any risk. But you can do MRI or EUS, and that has been proposed. And obviously MRI, as we mentioned before, may be the most cost-effective technique. Maybe not the most sensitive one, but at least the least invasive and probably the most cost-effective. But again, pancreatic cysts and pancreatic cancer or hereditary pancreatic cancer, not a real relationship there. It's mainly for the cancer itself.
So in monitoring those patients, it's not a question of what you do first, it's how often do you do it?
Yeah, and I don't think it's a fantastic question. I don't think we know exactly because there are no long-term studies that really can tell you 6 months versus 12 months versus 2 or 3 years. So most patients actually get a yearly scan and plus minus CA19-9. Usually the CA19-9 is so easy, and in the absence of another explanation for elevation, it may guide you. Again, being very non-specific, always we have to take that into account.
Okay, Peter, another question for you. You mentioned adding back in a probiotic if you were worried about bifidobacterium being low with the diet. And what's the correct dose to use? Which one to use? How long to use it?
I think the best dose is 0. The evidence for probiotics in IBS is there is evidence for some. People do meta-analyses where they put all the probiotics together and show benefit, which is, is a meaningless one to do. What they did, I think they used VSL number 3 or whatever it's called now, or whatever it's similar to, in that study. And what they were trying to do was just show the bifidobacteria were just as prevalent as they, just enriched as they were before they put them on the low FODMAP diet. The only thing was that they didn't improve their symptoms because it was a 2-by-2 study and they looked at the probiotic by itself and it had absolutely no effect on symptoms. So I don't think there's any advantage, but my recommendation for probiotics is if you want to use it, I'll tell patients to use one. We'll give them some which have got evidence-based. I think there's about 3 of them in Australia out of 100 probiotics marketed, and say to try it for 4 weeks. If it helps you, great. If it doesn't help you, for heaven's sakes, don't keep taking it.
I think that's always sound advice. Okay, and another one for you, Andreas. What pancreatic cyst size for a mucinous lesion will you send the patient for endoscopic ultrasound if there's no other risk of malignancy?
So it's a great question. If you have a mucinous cystic lesion and the patient is a surgical candidate, you should consider surgery as the first option, even without an EUS evaluation. Obviously, the EUS proves to be quite helpful in distinguishing mucinous versus other lesions because we can put a needle through it and aspirate and send it for CEA, mucin stain, and things like that. So the diagnosis may actually be confirmed by EUS. So more than triaging tool is a diagnostic tool still, but once the diagnosis of mucinous lesion is established, the patient should be considered a surgical candidate or not. If it's not a surgical candidate to begin with, well, EUS may not be the way to go. You should maybe stay with your MRI that's suggesting a single compartment, even 3 or 4 centimeter lesion, but you're not going to do anything different. You are going to gain very little by telling the patient, hey, the lesion you have in the pancreas has this first name and this last name, and your risk is this, and the patient is going to be, well, I wasn't going to do anything different to begin with. I'm still going to stay with my lesion and live happily ever after. So it's more of a diagnostic tool rather than a triaging tool. If you get a diagnosis of cystic lesion that's mucinous, surgery should be recommended.
Okay, great. And Peter, the last question goes to you. You need to put your celiac disease hat on. It says, is there a relation of the gluten-free diet and increased mercury and arsenic levels in the blood? If so, do you worry about that and measure it, whatever?
Well, it was all came from work showing that if you eat more rice, there's more arsenic in rice. In America, I'm not sure if it's the same in Australia, but I think it was. I really don't know about the serum levels.
Yeah, they're sort of infinitesimal, as I recall.
Yeah. I don't think. I would say that was one of those theoretical reasons not to go on a gluten-free diet if you don't need it, and I just can't understand why anyone would want to go on a gluten-free diet unless they had celiac disease. But that's
It's
my
very
own
popular,
personal
though.
opinion.
At least the sort of gluten in air quotes free diet.
But it was interesting that there were a lot of people were saying how wonderful gluten-free diet was for many reasons, and it was just counter arguments came in, which are fairly scary if you're having lots of arsenic. But I think if you wash the rice, it's supposed to be all right before you put it in the pot.
All right, well, we've run out of questions.